Assalamualaikum. I am Professor Shahena Akter. Welcome you all to this 5 days long workshop on Transvaginal Sonography, Colposcopy and Hysteroscopy. We are very much enlightened that Dr. Sonal Panchal from Ahmedabad, India is along with us as a foreign faculty, but we have also grateful to Professor Rokeya Begum and Professor of Radiology, Professor Alam. They are with us as local faculties in this workshop on Transvaginal Sonography on today. This program is designed as a lecture will be provided by Professor Dr. Sonal, and it will be followed by live demonstration of transvaginal sonography of different patients. It will be an interactive session. Everybody can participate with this hands-on training. Please cooperate with us and enjoy this session. Again, I welcome you all in this program. Assalamu alaikum. Thank you.
Assalamu alaikum. Honorable Principal, Head, Department of Obstetrics and Gynecology, Chittagong Medical College, Professor Dr. Shahena, Akter, our renowned gynecologist, Professor Rokeya Madam, and our prestigious guest, Dr. Sonal Panchal, and Professor Radiologist, and all my senior and junior colleagues. Assalamu alaikum. A very happy morning. So, I am Dr. Begum, junior consultant, going to introduce today's our prestigious guest, Dr. Sonal Panchal. She is actually a distinguished sonologist, renowned for her expertise in the field of diagnostic ultrasound imaging. She is an esteemed consultant sonography specialist at Dr. Nagori's Institute for Infertility and IVF in Ahmedabad, known for her profound expertise in ultrasound imaging, particularly in the fields of infertility and obstetrics. With an extensive educational background and a career dedicated to advancing ultrasound practices, Dr. Panchal stands out as a leader for her precision, dedication, and contributions to advancing ultrasound technology and practices. Dr. Panchal holds a PhD from the Sarajevo School of Science and Technology in Bosnia and Herzegovina, specializing in ultrasound in obstetrics and gynecology. She also earned a Master of Ultrasound in OB/GYN from the prestigious Ahmedabad Inter-University School of Medical Ultrasound. Her medical degree in radiodiagnosis further solidifies her foundational knowledge and skills in medical imaging. As a professor at Rokeya International University in Croatia and a faculty member for Ahmedabad Master's courses in ultrasound, OB/GYN, and human reproduction, Dr. Panchal is dedicated to educating the next generation of medical professionals. She also serves as the National Academic Director for the Ahmedabad School in India and is the Director of the Center of Excellence for the Ahmedabad School Inter-University of Medical Ultrasound in India. Dr. Panchal has a specialized expertise in infertility, gynecological and high-risk obstetric scans, utilizing advanced technologies such as Doppler and 3D, 4D ultrasound. She has trained over 800 doctors across India in ultrasound applications for gynecology and infertility and has been a faculty member for 3D, 4D ultrasound and infertility training programs both nationally and internationally. With a remarkable records of delivering more than 900 guest lectures at various state, national and international conferences, Dr. Panchal is a sought-after speaker and educator. Presented and published several papers at national and international conferences and in several journals. Her original research work on follicular monitoring, endometrial receptivity and PCOS has been widely recognized and published in several prestigious journals. She is a National Advisory Board member for the International Journal of Infertility and Fetal Medicine, JIB publications, and a reviewer for the Journal of Human Reproductive Sciences. Regarding trainings, Dr. Panchal's commitment to continuous learning is evident through her advanced training in 3D 4D ultrasound from Professor Ratulchuri in Vienna, fetal echocardiography from Professor Ravi Chaui in Berlin, and volume ultrasound in urogynecology from Professor Yang in Taiwan. She also conducts fellowships programs in ultrasound and infertility recognized by the Gujarat State University. With a career marked by excellence in clinical practice, education, and research, Dr. Sonal Panchal is a pioneering force in the field of ultrasonography. We are proud of you, ma'am. She is dedicated to improving patient outcomes through innovative diagnostic techniques and comprehensive training programs. Book edited by Dr. Sonal Panchal, she has edited a significant number of books in the field of ultrasound and gynecology, highlighting key titles. Some of them are Ultrasound in Infertility, Routine Applications and Diagnostic Challenges, Ultrasound for Congenital Fetal Anomalies, Ultrasound in Infertility and Gynecology, Text and Atlas, Sonal School Textbook of Human Reproduction and Gynecology and Endocrinology, Handbook of Infertility and Ultrasound for Practicing Gynecologists, Practical Guide to 3D 4D Ultrasound in Obstetrics, Gynecology and Infertility, Practical Guide to Infertility Management and IVF, etc. Her contribution in books, Dr. Sonal Panchal's contribution to 146 books demonstrates her profound impact and expertise involvement in the field of ultrasound, gynecology and infertility. From editing authoritative text to providing chapters, her contributions have undoubtedly enriched the knowledge base of practitioners and researchers worldwide. With his contribution, Dr. Panchal has played a pivotal role in advancing medical ultrasound and improving patient care in these critical areas of healthcare. Dr. Panchal's approach is characterized by a patient-centered philosophy, ensuring that each individual receives personalized care and attention. Her proficiency in using state-of-the-art ultrasound equipment, combined with her keen analytic abilities, allows her to detect and evaluate a broad spectrum of medical conditions with remarkable accuracy. As an advocate for continuous learning and innovation, Dr. Panchal remains at the forefront of advancement in ultrasonography. Thank you, madam. This is a so valuable and prestigious CV I have ever seen. Thank you, ma'am. Thank you all.
Bismillahirrahmanirrahim. Respected Principal, Chittagong Medical College, our guest speaker, Dr. Sonal Panchal, sonography specialist at Dr. Nagori Institute for Fertility and IVF, Ahmedabad, India, and my dear Dr. Brethren, Assalamu Alaikum. We know that our workshop is going on from today on Transvaginal Sonography, Colposcopy and Hysteroscopy. We know that we can diagnose our vaginal or fallopian tube or gynecological so many diseases that we can, those who cannot diagnose in normal sonogram, we can diagnose through transvaginal sonography. Already I discussed with Principal Madam, we have no transvaginal sonography machine here and hysteroscopy machine. We will try to bring and contact with our Director Medical Services to bring those machines so that our doctors will be benefited as well as our patients will be benefited. We know in Chittagong Division, 4 crore people depends in this hospital. Our doctors learn and our postgraduate student also, they will be benefited if we bring such type of transvaginal sonography machine and hysteroscopy machine, as well as our patient will be benefited. I would like to thank Medical Education and Health Manpower Development, DGMing and Department of Obs and Gynae who organized today's workshop, which will continue for 5 days. I expect our doctors and also our postgraduate students, they will be benefited such type of organization. I will request Madam so that our CMCH doctors, so that they can join today's workshop program. Yesterday I discussed with our CMCH doctor, gynecology doctor. They told me, give me an invitation letter so that we can join in this program. You know, our military doctor, they cannot participate such type of program without DGFA clearance. It is better to send an invitation letter for our military doctors so that they can enrich their knowledge. But
you are the authority of this program. This program is the program of Chittagong Medical College Hospital. So you can invite them to attend this session.
okay, thank you, Madam. I will tell them so that they can organize from today till finish this program. Thank you, Madam. I hope our workshop will be very successful and fruitful, and we learn so many things, and we will enrich our knowledge through such type of workshop. Thank you, Madam.
Professor Rokeya Madam to say something regarding this program. Madam was so much curious. So, Madam, please.
Thank you, Ranu. Ranu is doing a lot of job for organizing this workshop. First of all, thanks to Sonal. I know him from last 20 years. Every conference and seminar, there is a Sonal. Give a lecture on some different type of sonography lecture by Sonal. She is so dedicated and so laborious. She is running from Ahmedabad to Chittagong in a 1 day. And everybody like my junior colleague follow Sonal, how she is active, laborious and dedicated, and to give good educationalist to teach the student. That is necessary for us to build up the nation. And thanks to the Bangladesh government health ministry to organize this workshop and give a facility to come to Sonal to Bangladesh. Thank you.
Thank you, Madam. Now, I would like to request our prestigious guest, Dr. Sonal Panchal. Ma'am, everyone please be ready and attentive. Ma'am, please deliver your lecture. We are eagerly waiting for your lecture and wish a happy learning. Thank you.
Good morning all, and it is indeed, I cannot express my excitement and my joy that I am here today with you all. My sincere thanks first to Professor Rokeya Begum, very close friend, and she is instrumental in bringing me here. Thanking very much Dr. Famida for facilitating everything for me, starting from my tickets. She booked my tickets. We had to cancel the tickets because it was all a lot of chaos in there. Booked again, and she's always been after me for all my anxieties and for all my stresses that I had before I came here. And thanks to Dr. Ranu also, who spent 2 hours of hers at the airport for me, waiting for me. So let's start right away without wasting any time on other formalities. Thank you very much, and it's my honor, sir, madam, to have you here, director, sir, and professor of radiology, sir, here. So it's an honor, and a lot of other senior people who are here. So it's truly an honor and a respect to me, sir. So let's start right away with the session. And I know that, I've just come to know from what Director Sir was talking, probably transvaginal scans are not very easily available here. And I also believe that maybe it is because of that even your female patients are not ready for transvaginal scans. They're not absolutely always ready for the transvaginal scan, but believe me, transvaginal scan is one modality which gives you maximum information in a single non-invasive test. So mastering transvaginal sonography is not mastering a different art, it is just acquiring your own fingers with some extra abilities. And those extra abilities are much more probably than any other investigations or tests that you do. Moreover, it's non-invasive. So it's something which is worth mastering. So, no, I'm not taking. Slide is there. They have to start. My projector. No, they all set. It is there, madam. Okay, so let's truly learn the transvaginal scan systematically. When we do an obstetric scan, most of us, if we are doing obstetric scans, we have gone and learned somewhere as to what is the correct biparietal section, what is the correct abdominal section, and so on. But when it comes to transvaginal ultrasound, that's when unfortunately no systematic training is available, and therefore there is always a confusion in transvaginal sonography, not only about the pathology, but sometimes also about the laterality, whether it's right or left, whether it is anterior or posterior, and so on. Yes, it is true that when you want to assess the pelvic structures, that is when, can you switch on this fan, or it is not possible? Or maybe that AC, because it is too hot over here. So when we want to assess the pelvic structures, the uterus, ovaries, and the tubes, and the adnexa, and so on, that is when we can approach it either by a transabdominal scan, we can look at it by the transvaginal scan, or we can do a transrectal scan. Though transrectal scan is very sparingly used, it's being used only for those patients in whom you need to see and assess the pelvic organs very closely. But unfortunately, the vaginal route is not available. Maybe because the patient is virgin or she has a severe vaginismus. can start. It is okay if it doesn't work. Don't mind. Don't mind. It's okay. I'll manage. But if we are all settled, probably you will be able to gain everything that I'm speaking. Otherwise, I'll also lose my tempo. So. Are we all set? Thank you. Should I start? Yes. So that means that transrectal scan is very rarely done, but it can be done as simply as you do a transvaginal scan. But always prefer a transvaginal for all your fertility scans at least. Transabdominal route. Yes, it is true that every book writes that before starting a transvaginal scan, you must do an abdominal scan, and I don't disagree to that at all. But as a gynecologist, we are more capable of understanding the anatomy, the vaginal route. It is a slight, I would say, it is a little difficult for a radiologist to understand the anatomy of the pelvic anatomy, the vaginal route, because it is the abdominal route that has been taught. Not that nobody can do it. A lot of people can do it, but you have to clearly understand the anatomy, the vaginal way. But that is a boon to the gynecologist because we have learned the anatomy that way, and therefore what I do for my patients is that if I am doing a transvaginal scan and if I can not see all the margins of the uterus and the ovaries or lesions arising out of that completely on my vaginal scan, I would definitely do an abdominal scan. You can follow any of the two techniques. You can either do abdominal scan for all, or you can start with vaginal and if required do an abdominal scan. But whenever you do an abdominal scan, there are a few things important. You know that because the pelvic organs are quite far from the probe that you place abdominally, therefore you will always have a poor resolution of the uterus and the ovaries, and therefore lots of details about the ovarian anatomy especially can be missed when you are doing an abdominal scan. So it's doing a scan for pelvic organs abdominally, or even small fibroids and lesions of the uterus, or even sometimes the endometrial morphology may not be in detail studied. When, of course, we do it with a full bladder, but still, when we have a problem finding out the uterus or the ovaries on the abdominal scan, that is when it is essential that you would press the probe and bring the probe as close to the So you should place the probe, when you place it on the abdomen, that's when it is essential. You don't just press like that. Posteriorly, you have to always angulate it towards the inlet of the pelvis, and that is an important technique as it is clearly shown here in the image. So you press the probe towards the inlet, angulate it and press it towards the inlet so that you can see the uterus and the ovaries better. When we are doing a trans-abdominal scan, that is when the orientation of the image is not at all difficult, because we all know that we have put the probe here, which is on the abdominal wall. So this is the anterior aspect of the patient, and this is the far end, so that is the posterior aspect of the patient. Remember, whenever you are doing the scan, you know that the probe has a marker. Do you know the probe has a marker? And that marker always correlates with this logo here, with whichever brand machine you are using, the logo correlates with the marker. That means that when you start your scan, always your probe marker should be towards the head of the patient. You cannot just place the probe anyway. In the longitudinal probe position, the marker of the probe should always face the head of the patient, and if that is the case, that is when, because the logo is here, therefore this is the cephalic end of the patient and that is the caudal end of the patient. Very importantly, when you, is my voice consistently coming? It's okay. When you want to do a transfer scan, that is when it is essential that you always rotate your probe 90-degree anti-clockwise. You have to rotate your probe 90-degree anti-clockwise, because when you rotate it anti-clockwise, that's when the marker which was facing the head of the patient is now on the right side of the patient. And the logo also on the transfer section is on the right side. So the right side of the patient is, right side on the image is the right side of the patient, and left side on the image is the left side of the patient. There is probably a erroneous concept if people would rotate it on the right side for the right ovary and on the left side for the left ovary. Remember, once you have rotated the probe, or even if you have not rotated the probe, if you want to see the structures on the right side, you should span the probe or angulate it on the right side. If you want to see the left, you have to span the probe on the left side and angulate it on the left side. So the rotation for the transverse section is always anti-clockwise. You can see the right ovary or the left ovary depending on you have spanned and angulated on the right side or on the left side. So that is important about the transabdominal scan. Coming to the transvaginal scan, of course, you all know that we do it with an empty bladder. You know that we would always counsel with the patient. We will inform her what we are going to do, and we will take her verbal permission, and then we will do a scan. As you introduce the probe, so even before you introduce the probe, the first important thing is that the position of the patient is very important. If you try to do a pelvic scan, a transvaginal scan on a flat bed, don't expect great miracles, because when you are using a flat bed, even if the patient is in a lithotomy-like position, there is no place for your probe to move. And therefore, you cannot approach absolute anterior structures, or sometimes even you would have difficulty into moving your probe onto right and left. So remember, as a rule, transvaginal scans must be done on either a gynae couch, or it should be a dedicated bed designed like this, where of course, like the gynae couch, it has a notch there for the buttocks, but it should have long foot arms. When there are long foot arms, that is when the patient can slide right up to the edge of the notch and still rest her feet and bend her knees completely, and you have a lot of space there to move your probe, and you will not have a difficulty. So that is one very basic thing that we need to always understand and follow. You don't need a separate bed for obstetric scans, so don't think you have to have 2 examination beds. This, if you can see, has a long length. So what we do is, if the patient is on a transvaginal scan, her head will be somewhere here. But if it is an obstetric scan, we will allow her to slide up, and she can put her two lower limbs straight on the 2-foot rest. So that is about the position of the patient, which is very important. Then introducing the probe is a second problem. Many a times, it is quite a resistance before you can introduce the probe. And if that is the case, what needs to be done? The first thing, ask the patient to breathe out forcefully. Full expiration, not blowing. No, not that. And when that happens, all the 3 orifices relax, and your probe can slide inside the vagina through the introitus very smoothly. Don't ever screw in the probe, because even when you are doing a vaginal scan, that is also when the probe, the marker on the probe always has to remain facing the anterior aspect of the patient, so facing the roof. If you screw in the probe, you don't know where that marker went. So it is always important to gently slide the probe inside through the introitus when the patient expirates out. If that does not help, and you still have to exert some pressure, don't exert the pressure inside like this on the introitus. Press posteriorly on the anus. That will immediately make the vagina more spacious, and it will be easy to introduce the probe through the introitus. Rarely will you need to do any other maneuver like folding the thighs completely on the abdomen to allow a more space into the vagina. So those are the important practical clues which we need to follow when we are doing a vaginal scan. Then coming to the next thing, and that is the probe movement. Remember that when you are doing a transvaginal scan, every movement of the probe is going to irritate the patient. It may cause pain or may cause irritation, and therefore you should not make any unalert movement. Many of us may have a habit to put in the probe, moving here and there when we are doing something else. Our mind is engaged somewhere else. And then suddenly we are seeing the uterus, you say, yes, I've got the uterus. No, that's not the way you do the scan. You should, in every movement of the probe has to be an alert movement, because every movement of the probe gives you an information. So the first movement of the probe is in and out movement of the probe, which we all know is for the introduction of the probe and removal of the probe, but it is the movement of the probe that you do to assess the mobility of the structures or to rule out adhesions. So whenever, say for example, you are seeing that ovary and you are seeing the lesion, or you are seeing a uterus and the ovary placed side by side to each other, or sometimes you may also be seeing, say for example, a fibroid, you don't know it is this still on? No. This is the screen on now. So for all these cases, what you need to do is, you are seeing the ovary, you are seeing the lesion, and you would press the probe in and out, and as soon as the screen starts, you will see that you can either separate the two from each other, as you are seeing here, or you can slide the two over each other, which tell you, yes, these two structures are not adherent to each other. Say for example, if it's an ovarian, it's a lesion which you suspect it's ovarian or extra ovarian, if you can do a positive sliding organ sign, you can slide the two over each other, which means that the lesion is not arising out of that organ. But if you see here, you can move the bowel loops in relation to the ovary, but you can see this is the lesion, this is the ovary. When you do in and out movement also, the relationship of the ovarian tissue with the cystic lesion does not change. That means this is intra-ovarian, or that it may be adherent. This is of course intra-ovarian, but it could always also be adherent to the ovary. So that is why we do the in and out movement of the probe. The second movement of the probe is rotation movement, and just like the abdominal probe, even the transvaginal probe, the rotation is always to be done anti-clockwise, and it needs to be only in the left half of the clock face. This is the clock face. If you are seeing, this is 12 o'clock, this is 6 o'clock, 3 o'clock and 9 o'clock. Move your probe only in this half, never take it onto the other half. Why? Because again, when you do that, that is when your marker goes onto the right side. If the marker goes onto the right side, the logo is also on the right side. So just like your abdominal scan, the right side means right side and the left side means the left side. The right side of the image is the right side of the patient, left side of the image is the left side of the patient. So that is why you always do the movement of the left side. Whenever you move the probe from there to 6 o'clock and then go beyond, that is when the entire direction changes. So much so that the anteverted uterus will appear retroverted. So please be careful, don't move the probe onto the other side. And the rotation is done to evaluate any structure or organ lesion into longitudinal and the transverse planes. The third important movement is the side-to-side movement for longitudinal survey or for the side-to-side survey of any structure or lesion, and this is up and down movement for entero-posterior assessment. These two movements can be combined with the rotation movement also, so you can rotate the probe and then move. When you rotate the probe and then move, that's when you are seeing the transverse section and you are doing a transverse survey. If you are doing with the longitudinal, you may be doing a longitudinal survey. So those are the probe movements that are important. Now coming to the orientation of the image. So that also is sometimes a problem in the transvaginal scans. And though we have already discussed that, the logo indicates the marker, and the marker on the vaginal probe is always facing anteriorly. If we understand this image, this is the probe head, footprint of the probe. That means, and that is in the vagina, so that is the caudal end of the patient. Yes. And this is the far end, so this is the cephalic end of the patient. The logo is here, so this is the anterior aspect of the patient and this is the posterior aspect of the patient. Are we clear, all of us? Now with that, let us understand what is the orientation of the uterus here. Because the external os to internal os, the cervix is progressing anteriorly and the fundus is also going anteriorly. That means it is an anteverted anteflex uterus. We all agree? As Madam has said, this is an interactive session. So if you don't understand, raise hand and tell me immediately so that we can correct it, okay? So that's an anteverted anteflexed uterus. Whereas, if you look at this is a retroverted retroflexed uterus because from external os to internal os, the cervix is progressing posteriorly and the fundus is also going posteriorly. It is not essential to see the bladder. Your orientation is always the same, and if it is the uterus which is seen like this, it is anteverted anteflex. If it is seen like this, it is retroverted retroflex, and there cannot be any other doubt or an option to that. If that is the case, let us also identify the walls of the uterus because that is where we have a lot of confusion many a times. So this is which wall of the uterus? Interactive. Come on. Anterior wall of the uterus. Nobody has a doubt, right? And that is the posterior wall of the uterus. And this one? This is the posterior wall of the uterus and this is the anterior wall of the uterus. Now, you don't need to mark this up. Always have to understand in relation to the cervix. Say for example, if for this image I said that this is the anterior aspect of the patient and this is the posterior aspect of the patient, instead of taking the entire image into consideration, if I am taking only this half of the image which contains cervix, yes, even then this is comparatively anterior and this is comparatively posterior. Do you agree? Yes. So if we take cervix, this is anterior lip of cervix, posterior lip of cervix. And this wall is continuation of the anterior lip of cervix, so that is anterior wall of uterus. And this is continuation of the posterior wall of cervix, so that is posterior wall of uterus. Whereas if we are seeing this, again the logo is here. So this is anterior aspect of the patient, that is posterior aspect of the patient. If you take only this half of the image into consideration, this is still comparatively anterior and this is still comparatively posterior, yes or no? Yes? Yes or no? No? Why? If I am taking the entire image, this is anterior, this is posterior. If I am taking only this much part, even then this is comparatively anterior, this is comparatively posterior. That doesn't change, right? And if you see the cervix, then this is the anterior lip of the cervix, continuing as the anterior wall of uterus, and posterior lip of cervix, continuing as the posterior lip of uterus. If you still have confusion, this is your anteverted anteflex uterus. Palm is anterior, dorsum is posterior. We all agree to that, right? So this is your anteverted anteflex uterus, and this is your retroverted retroflex uterus. Where is the posterior wall gone? You understand? You understand? Yes? So now we should not have a confusion as to which is the anterior wall and which is the posterior wall of the uterus. In the mid-post uterus, the anterior posterior does not change. But what is important? When there's when there's a mid-post uterus, that is when it is very, very difficult to assess the endometrial morphology. Why? If you look at all these lines, all these images, the endometrium is almost perpendicular or has an acute angle with the direction of the sound beam. The direction of the sound beam is perpendicular to this footprint. So the endometrium is absolutely or close to right angle, perpendicular to the sound beam. But if you see here, the endometrium is parallel to the sound beam. Because it is parallel to the sound beam, it doesn't hit the endometrium and come back. It passes through the entire length of the endometrium, and because it passes through the entire length of the endometrium and it doesn't reflect back, every endometrium in that position appears hypericate. So what you should do is, if the uterus is mid-post, you can place your probe either into the posterior fornix and try to lift it up, or go into the lateral fornix and try to move it medially so that it becomes perpendicular to the sound beam. But if you cannot do that, that means that the uterus is that means that the uterus is fixed in the mid-post position, and if it is fixed in the mid-post position, that is when, if you are seeing the endomyojunction very clearly as you were seeing here, what is endomyojunction? Endomyojunction is this hypoechoic area on the outside the outer margin of the endometrium. So if you can see that clearly, you can still measure the endometrial thickness, but whenever it comes to the morphology of the uterus, it is always essential that you would go through the abdominal route, mid-post uterus, which cannot be corrected by the probe manipulation. To evaluate the endometrial morphology, take the abdominal route. It is also better to measure the endometrial thickness in the same abdominal route, by the same abdominal route, because it is possible that when it's mid-post uterus and you try to measure, you may not be measuring the endometrial thickness in the sagittal plane, you may be in a mid-coronal plane sometimes. And then the thickness measurement will be wrong. So that is one indication where you would need to do an abdominal scan. Now as you push in the probe, that is when ideally you should see the uterus in the mid-sagittal plane. So uterus's own mid-sagittal plane is where you are seeing the entire endometrial cavity and you are seeing the cervical canal both in the same axis. Okay. That is the mid-sagittal plane of the uterus, and normally we know that the uterus is a mid-sagittal or it's a mid-position organ. Therefore, as soon as you put in the probe, that is when you should ideally see the uterus like this. But if you are not seeing it like this, you are not seeing the mid-sagittal plane at all, you are not seeing the endometrial cavity, you are not seeing the cervical canal, but you are seeing the myometrium, or you are not seeing the uterus at all, which means that mostly the uterus is deviated. And you span the probe from one side to the other side, and you can see the mid-sagittal plane of the uterus. This tells you the uterus is deviated onto one side. And if it is deviated onto one side, you know that it might be because of a Mullerian abnormality or maybe some extrauterine pelvic pathology, maybe even adnexal, which is pushing or pulling the uterus onto one side. So you're thinking about the abnormalities, search for the abnormalities, start right from the minute you introduce the probe. Instead, if you put in the probe and you are seeing either the endometrial cavity or you are seeing the cervical cavity, but you are not seeing the entire mid-sagittal plane, which means that the uterus is mostly twisted. And if you rotate the probe and you see the mid-sagittal plane, it tells you, yes, it is truly a twisted uterus. And if it is a twisted uterus, the common things that you would think about is of course either an adhesion or it may be a large pathology in the uterus which is involving the uterus asymmetry. So from that very point you start thinking as to what is the pathology, and therefore it is very essential that you would always introduce the probe yourself. Many of us, busy practitioners, we may be busy with the consultation. We also have to do the vaginal scans. We also have to go and operate. In those cases, we often make a habit to tell the junior or a nurse, go introduce the probe, go give the position, introduce the probe, I'm coming. And this is where you miss all the information. Why? Because ideally you should start seeing the image the moment your probe is right on the introitus, and when your probe is on the introitus, you are seeing here the symphysis pubis, the hyperechoic triangle area is the symphysis pubis. You're seeing the urethra here, you're seeing the bladder here. This is the posterior muscular wall of the urethra and the bladder. That is the interface between the anterior vaginal wall and the urethra. This hyperechoic dots you are seeing is air in the vagina, posterior vaginal wall. And you are seeing the hyperechoic bowel lumen here and the anterior muscularis. As you gently introduce the probe, you can see the splaying of the anterior and the posterior vaginal walls. And you can now also appreciate clearly the interface between the vagina and the bowel. So you should introduce the probe inside, come back once, go again in. If you are not sure about the free sliding movements between these tissue layers, that's when you will have to do an additional maneuver to evaluate the posterior compartment. If the sliding movement is not there, that means there is some adhesion. If there is some adhesion, it may be the commonest deep infiltrating endometriosis. It may be inflammation, post-inflammatory. It may be post-operative. So it means there are adhesions between the tissue layers and you need to find out the cause. As you gently introduce the probe then inside, you will touch the cervix. And as you touch the cervix, you are seeing fluid in the cervical, in the vaginal cavity. You are seeing the thin vaginal wall here. You are seeing the peritoneum over the vagina. You are seeing here the posterior lip of the cervix and the anterior lip of the cervix and the cervical canal. Gradually go in, and that is when you would see the uterus. Yes? So that is the information about the vagina, about the cervix. Many times we come across cases where patients say, oh, this reminds me. Just last week we had one patient who got an MRI of the pelvis done. Why? Because the Bartholin cyst was not seen on ultrasound. That is not possible ever. If you don't introduce the probe correctly, you will not see it. But otherwise, it's not possible that you have not seen it. So it is very essential to do the scan very carefully. And as you introduce the probe, you must always keep on looking at the scan. Now, if you look at this scan, if I've introduced the probe inside and I'm not seeing, as I told you, I'm not seeing any part of the mid-sagittal plane. Right? And the moment I span this probe, I will see the mid-sagittal plane. That tells me the uterus is deviated. So that's what I meant to tell you when I said that you can identify whether it's a deviated uterus or it is a twisted uterus. Now, even if it is a deviated uterus, first find out the mid-sagittal plane of the uterus, and once you have found out the mid-sagittal plane of the uterus, that is when you would then span across the uterus from one side to the other side and evaluate the smoothness of the serosal contour. You would check both the myometrial walls. Both have to be almost equal in thickness and isoechoic. You would always have to check the junctional zone, the endometrio-myometrial junction, which is an hypoechoic area surrounding the endometrium. And you would also go to the endometrium to check not only the shape of the endometrium, but also the central line. The smoothness of the central line is important. because many a times you may have small polyps and they would only show irregularity of the central line. They are so small that and subtle in echogenicity that you will not be able to otherwise identify them. But because you are seeing that central line irregularity, you can put on a Doppler and you will know that yes, there is probably some pathology here and there. Then once you have introduced the probe and you have finished assessing the uterus, angulate your probe towards the cervix. The cervix in an anteverted, anti-flexed uterus is posterior. So angulate your probe slightly posteriorly, and when you do that, that is when you will see the cervix. Once you see the cervix, always pull out the probe a little. When you pull out the probe, see, you can see both the lips clearly, you can see the canal also clearly. So your cervical polyps cannot be missed then. And once you have finished doing that, and evaluated the cervix, you can go and check the mobility. If I say evaluate the cervix, it is not only for the pathologist, it is also to find out whether the cause of infertility is cervical or it is something else. Because, and the second important thing is you always need to find out the cervical length. If you are going to do IUIs, the semen sample needs to be released in the endometrial cavity and not close to the fundus, because when you go close to the fundus, it is a possibility that your entire sample would flow into one of the tubes. So you should always release it in the endometrial cavity, and therefore you need to know the cervical length. The length of the IUI cannula that you will introduce will be 1.5 centimeters plus the cervical length beyond the external os. So how will you measure the cervical length? You have to identify the internal os and the external os. The external os is beautifully seen there. There is no problem at all. You are seeing the vaginal wall, you are seeing the fluid, and you are seeing the external os. But the internal os is to be identified by the presence of the cervical glands. As a gynecologist, you would think we would find out the uterine vessels, but uterine vessels are not in the mid-sagittal plane that you are doing a scan in. The curvature of the uterus is always not present, it may be straight also, so that is also not an identifying point. Sometimes you may be able to find out the level of the bladder, peritoneal reflection, and would say, but that is also always not easy. But you can always identify the internal os by the cervical glands. You all know that cervical glands are the structures which are present in the cervix, not in the uterus ever. And the cervical glands can always be seen as a separate, subtly different echogenicity and a very thin hypoechoic line between the musculature of the cervix and the cervical glands. So identify the cervical glands and see this papers here. Yes, so that is the internal os, and measure the cervical length. For obstetrics, we are taught to measure the cervical length by the straight line. For infertility, we are going to measure it as a curved line always. So measure the cervical length, and we would be done with that. But there is something very important and interesting. If I told you that cervical glands assessment would tell you whether the cause of infertility is cervical or not, very interestingly, the cervical glands in all other phases of the cycle, they are hypoechoic, as you can see here also. It is hypoechoic. You can see here it is hypoechoic. Yes, but in the periovulatory phase it is always hyperechoic. So if the cervical glands turn hyperechoic in the periovulatory phase, that means there is sufficient secretion, there is sufficient effect of estrogen on the cervix, and therefore most likely it's not going to be a cervical factor in fertility. Check by in and out movement of the probe for the mobility of the uterus, and also check for the mobility of the cervix. Look at the bowel movements around the fundus and look at the bowel movements around the cervix also. Having done that, now you would move to the transverse section. Remember, when you move to the transverse section, always bring the uterus fundus in the center and only then rotate the probe, because only when the fundus of the uterus is in the center, when you rotate the probe here, you will be cutting in the center. So ideally this is also not the position, the fundus should be seen here, and then you rotate the probe. And that can be done by anterior angulation if it is an anteverted uterus, that can be done by posterior angulation if it's a retroverted uterus. And then rotate the probe 90 degree anti-clockwise, and that will give you a transverse section. And on the transverse section, again I repeat, right side, left side, anterior and posterior aspect of the patient part. That is anterior and posterior aspect of the patient. Which wall of the uterus is this? If it is an anteverted uterus, it is an anterior wall. If it is a retroverted uterus, it is a posterior wall. Yes, so that is about the transverse section orientation. Now, once you have gone to the transverse section, you would do an up and down movement of the probe to span to evaluate the uterus in the transverse section. As you go towards the fundus, you can see here splaying of the two cornu, which tells you two cornu are present. You can also see in that so-called semicoronal section, there is a smoothness of the fundus, which even without your 3D rules out the possibility of duplication abdomen. And it also rules out the possibility of unicornate uterus, because you are seeing the two cornu there. And then span your probe down to the cervix, and that finishes your survey of the uterus. Having done that, quickly looking at the measurements, we would do this on the live also, but the measurements, if I say, it is always to be measured as a curved line when the entire uterus is seen. This is the anatomical uterocervical length, not practically important to us unless we have to diagnose hypoplasia. Then the second is measuring the effective endometrial length or the endometrial trace, which is from the fundal end of the endometrium to the external os. And then to measure the endometrial thickness and to measure the AP thickness of the uterus, the fundus needs to be brought into the center, and then you measure the AP diameter, the widest, the highest, the thickness of the uterus anteroposteriorly, but perpendicular to the central line always. And even the endometrium is measured as outer margin of the hyperechoic line to the outer margin of the hyperechoic line, and always perpendicular to the central line. So that's how you are going to measure the endometrial thickness. And on the transverse section, measure only the transverse diameter. Never measure the AP diameter or the endometrial thickness on that. Having done that, now we have to trace the ovary. If the ovaries are placed just by the side of the uterus, as we saw here in this image, we feel we are blessed, but I don't feel we are blessed, because when the ovaries are placed that close to the ovary, that close to the uterus, that's when you can actually not evaluate the soft tissue adnexal band, which consists of tube, ligaments, and vessels. Why is it important for me to look at this soft tissue adnexal band? Is because it is this band, the soft tissue adnexal band, which you see here. If I said it contains tube, ligaments, and vessels, tube may get inflamed, and acute salpingitis, which is almost always missed, can be diagnosed if you make a routine habit to check this soft tissue adnexal band. If the thickness is more than 1 centimeter, and if you see vessels which are running across, this normally also contains vessels which run from uterus to the ovary or ovary to the uterus. But if you see vessels running across in a low velocity, low resistance flow, it tells you it is acute salpingitis. When you suspect acute salpingitis, if you press on probe pressure, patient will complain of pain. Sometimes there will also be free fluid. And if you get a chance, also go and see the ovary. Even if you have not seen the ovary of that patient earlier, if you compare the echogenicity of the stroma of this ovary with the echogenicity of the myometrium, the echogenicity of the stroma will appear low, and if you put on the Doppler, there will be a lot of blood flow inside, which tells you there is pruritus also. uveitis and salpingitis you would otherwise not even think of diagnosing, but this is a very easy and a simple way. If you do a proper transvaginal scan, you can do it. So one is just by the side of the ovary, second is by tracing the soft tissue. See, you are seeing beautifully the soft tissue adnexal band here, and that leads you to the ovary. So that is the second way. If these two are the not the positions of the ovary, and here this is an inflamed tube. You are seeing that there is fluid surrounding, the band is thickened. You are also seeing that the ovary shows multiple small follicles only, and it is a hypoechoic stroma. So that tells you it is probably an uveitis, and in all these cases it will be pain or no pressure. If you don't find, sorry?
How do you understand that the band is thickened?
You have to measure. You have to measure. More than 1 centimeter, as I said. Now, if you, these are the two positions. I said one just by the side of the uterus. Second, we said tracing the soft tissue adnexal band. If you don't find ovary in these two positions, just angulate your probe posteriorly. Most likely the ovaries will be placed posterior to the uterus. And if that is also not the case, then span the probe right up to the lateral pelvic wall. As you go to the lateral pelvic wall, you will see two large vessels in long axis. These are the iliacs. From there, if you angulate the probe supromedially, you will see the ovary. This is the normal ovarian fossa. If you don't see the ovary in these four positions, that means the ovary is surely grossly displaced. Move your probe right up to the lateral pelvic wall. Span it up and down, absolutely up and down as you move from lateral to medial, till you reach the lateral margin of the uterus, and you'll find the ovary somewhere. And if you find the ovary there, again check the mobility of that ovary like you would check for the mobility elsewhere also. But when it is a grossly anteriorly or a grossly posteriorly placed ovary, if it is not fixed, it may have a long ovarian ligament, and these are the patients when you stimulate, you have to be very careful. They may result into torsion. If they are fixed, they may be a result of endometriosis or surgery or maybe inflammation. Locate the ovary, rotate your probe, find out the longest axis of the ovary and the longest section, and freeze it on one of the frames of the dual frame image. With the ovary in the center of the image, it should not be on the side. And once it is in the center of the image and you have taken the longest section, only rotate your probe 90° anti-clockwise, do no other movement, and that will give you the transverse section of it. Measure the longest diameter, measure the longest diameter perpendicular to the long diameter, and measure the longest transverse diameter parallel to the x-axis. These three will calculate the ovarian volume for you. Having done that, we would check for the mobility of the ovary also. You can see your bowel moving on the ovary. Here you can see the bowel, ovary and the uterus are side by side. You can see the bowel moving there, but you don't change the relationship between the uterus and the ovary when you press. That means the ovary is adherent to the uterus. What is very important. And then lastly, see the pouch of Douglas for not only fluid but any other pathology that you would see also. You would hope to see because of the clinical history of the patient, and then you would move to the Dopplers. But Dopplers we will do with the individual cycle assessment lectures. Evaluate the ovary by spanning across for any of the lesions. Check for any extra ovarian lesions also. As you can see here, there's a large hydrosalpinx with, this is also hydrosalpinx with a waist sign here. Waist sign is what? There's a narrowing in that cystic area. So you would see two parts of the cystic area with a narrowed area in between, which tells you it's a waist sign, which is because of the ostra. We will see on the live if we have, but or maybe in some other presentation. We don't want to spend time here. So check for any extra ovarian lesions, and that is it. What is important to remember? Never ever exert any pressure, undue pressure when you are doing transvaginal scan, because everything that we are seeing is a soft tissue. It can get D-shaped, it will lead to pain, will not allow you an optimal assessment. Even if the mic is not mic. Hello? Yeah? Okay. So, you can just take off the pressure a little. Don't remove the probe, but take off the pressure a little so that you can evaluate it without pressure. Whatever you see, always must be seen in two anatomical planes at least, the longitudinal and the transverse. A dynamic examination to check the mobility, to check the core pain on probe pressure is very, very important. Doppler is very important because Doppler helps you to differentiate lesions very, very beautifully and also assess the aggressiveness of the lesions. Understand the entire anatomy and if possible try to make a diagram, a pencil diagram of what you have seen. Correlate everything that you see with physiology because we know that ovary is otherwise also a host to several cystic lesions, which is a normal thing, and therefore don't always think of pathologies. First think of physiology. If it doesn't set into physiology, only then talk of a pathology. If you are finding lesions which clearly don't appear malignant in the ovary also, make a habit to always reassess them after 2 or 3 weeks rather than stamping a diagnosis, being in a hurry of stamping the diagnosis or getting a CT or an MR done. And always remember, there are lots of incidental findings that you would find when you're doing a transvaginal scan. Not that you don't have to mention it, you have to mention them all, but also mention whether they appear to be the cause of this patient's symptoms or not. So that is about the basic transvaginal scan. I know we have to go at 10 o'clock for the live demos, but before that we can quickly go through a little bit of understanding on optimizing of the image. Is that fine for you all? Because that will finish the basic and then we can go for question answers. Is that good or you want question answers first? Should I continue?
Yes.
So what do you need to know about the machine? Yes, I've written as Doppler basics, but it is not truly Doppler basics only. The first thing is that why do you need a Doppler? Where ultrasound, 2D ultrasound tells you only about the anatomy of the uterus, pelvis, uterus, ovaries, whatever. It is Doppler which tells about the functional status of the follicle, of the corpus luteum, of the endometrium and so on, because we know that menstrual cycle, which is a continuously changing, very well balanced orchestra of multiple hormones, it is this hormonal changes which reflect immediately into the hormone, the vascular changes, and these changes can be diagnosed by Doppler. Therefore, if you do the Doppler and if you can interpret it correctly, it will tell you about the instant hormonal status. And in countries like yours and mine, where not all people are affording, not all fertility treatments are insurance or not repaid by the government, that's where we have to opt for lower cost treatment and still effective treatment. And even if you do a hormonal test, you are still going to do an ultrasound. So why not just add a Doppler to it and interpret it correctly so that you can avoid a whole lot of hormonal investigations. And when I say that, I know that most of you will be not believing it or get astonished when I say that though we are a dedicated infertility institute with very high results, of course on IVF, but even better results on IUI, which is a low-cost treatment as you all know. We have about more than 17,000 pregnancies by now. With IUI, I'm not talking about IVF. IVF is separate. And at least about 200 plus cases where 3 or more IVF failures have conceived with IUI or with natural intercourse after treating the males. In spite of seeing so many patients, we do not do any hormonal investigations, and that's what we are going to correlate it with when we talk about the sonoendocrinology also. We don't do any FSH, LH, AMH, androgen, estrogen, progesterone. The only 3 investigations that we do is prolactin, thyroid, and and insulin resistance, and that is it. You don't need to do anything else, because when we do the test, we don't want the exact numbers. What we want is whether the level is high or low, is too high or it is too low. And that can be easily judged on your ultrasound, and that is why Doppler has a very important role to play. Of course, I know that we are all clinicians, we don't want to do any physics at all, but if we want to do a correct interpretation, we definitely require a good quality image, and to get a good quality image and a high frame rate, there are a few adjustments which we need to learn. I will not tell you what is a good quality or a good resolution image, because you all know that, we are all using mobile phones. We all select our mobile phones by the camera pixels, and we all know that more pixels is better resolution, less pixels per unit area is a poor resolution, and so on. So we want good resolution. The second important thing, which if I say frame rate, we know we are doing a real-time ultrasound. If we are doing a real-time ultrasound, that is when it is multiple 2D images which are coming one after the other fast, and if we compromise a little on resolution, maybe we can have a better frame rate. Whereas if we are having a very sharp image, we may have a little lower frame rate. But for every image, we have to decide, is the dynamicity important, is the 2D image important, and accordingly we may be changing from the resolution to the frame rate. And that is not a very difficult task, if I tell you. There are just a few adjustments and few knobs we need to know. We are using ultrasound machines, but we are not used to touch these knobs. We would only keep on working with the settings that are done by the application specialist. That is why n number of times it happens that we would see images, the images that may be produced would appear something like this. Something like this, yes, wherein the uterus, which is the area of interest, is covered only in the upper third of the image, and the rest of the information that goes to the scanner is absolutely useless. So the first important thing is that as soon as, no it's not Zoom, as soon as you switch on your machine, the first thing you would start your scan, the first thing you would do is you would open the angle of the scanner, of the probe completely, see as wide as you can, take a longitudinal survey of the uterus, then rotate the probe 90 degrees, get a complete view of the pelvis, the pelvic anatomy, locate the structures that are of your interest, and then first thing you will do is you will bring the area of interest right in the center as you are seeing here, and you will decrease the scanning angle. Because you decrease the scanning angle, the unnecessary information going to the machine will decrease, and the frame rate will improve, and even the visibility will be improved, because the reason is that the structures that you bring in the center of the image, the sound wind that hits it is completely reflected, whereas the structures which are at the side, usually what happens, if your angle is completely open and you are seeing the ovary there on the side, you will be satisfied, okay, I've seen it. But that doesn't give you an optimal view. You have to bring the ovary in the center, and when you bring it in the center, because the sound beam is hitting it perpendicularly, you are going, and the entire beam is going to reflect, you will have a much more clearer picture of the ovary, of the endometrium and so on. You know that the structures which are at the side, the sound beam will hit it, but it refracts more than reflects, and therefore the margins will not be clear. So first thing is setting the angle. The second important thing is setting the depth. The correct depth adjustment would be when the area of interest, so not this, but when the area of interest fills up at least 2/3 of the image. The area of interest, when it covers at least 2/3 of the image, this is the correct depth setting that would improve not only the frame rate, it would also improve the resolution, because the same number of pixels that you were using to see a 10 centimeter depth, now you are using only for 4 centimeter depth, and therefore the image visibility, the clarity of the image, the resolution is going to be always better. These pictures are put here. If at all you don't find where to adjust this on your machines, this will be the symbol which will indicate the depth. Angle will be written as angle most of the times, or it will be a box with two dashed lines and an arrow down there which will tell you this is the knob by which I can adjust the angle. The third important setting is what is called focal zone. When you do an ultrasound, you have a tiny triangular head, arrowhead, and this is what is you probably will see here better. Just a minute. Yeah, you are seeing here. Just one minute. You are seeing it here. You are seeing it here. So that is a tiny arrowhead that you see. It is called the focal zone. Electronically, the ultrasound beam is so treated that it gets narrowest at that level. Because it gets narrowest at that level, there is least of refraction, more of reflection. Image quality is the clearest there. So I always adjust the focal zone at the level of area of your interest. Moreover, the adjustment of the focal zone is also required because all the other settings that you would do will reflect most on the focal zone. Not on the other areas, but most on the focal zone. Therefore, it is very essential that you will always set the focal zone at the area of interest. If you sometimes have to see structures like this, where you are interested in the entire depth, that is when you can increase the number of focal zones. As you can see here, instead of one focal zone, there are 3 focal zones here. But look at this. Look at both the images where the probe movement is the same, but here the frame rate is much higher as compared to here, which means that when you use more focal zones, that's when the frame rate is going to be decreased significantly, and therefore make a habit not to work with multiple focal zones. Only when required, you can switch on to multiple, go back to the single focal zone. Zoom is very important, but most of the times we unfortunately take a shortcut and we zoom the image like this. Here we are only separating the pixels. We are not zooming the image, we are only changing the visibility. And this is what should not be done when you are doing active scans. It decreases the quality of the image, but you should always use what is called a box zoom. And the box zoom or the HD zoom is when you select a box and you zoom only that much area. You are not compromising on the frame rate, you are not compromising on the image resolution, and you get a high quality image with a better visibility and a better resolution. But remember that when you are doing a live scan, you need to use an HD zoom or a box zoom. But if you have already frozen the image or you have stored the image, that means you have already fixed the quality of the image. Now you can use a pan zoom. So when you just rotate the probe and you blow up the image, it is pan zoom. When you put a box and then you enlarge only that much portion, it is called an HD zoom. So HD zoom for the live scans, pan zoom only for the stored or the frozen images. I have not talked about gains. I have not talked about contrast positively because I don't want you to touch gains and contrast as far as possible. Contrast, please don't ever touch it once it is adjusted according to your eye training. So you have set with the application person when she comes to set the machine and you have adjusted the contrast and the gray map the way you want to. Now don't keep on touching it. Gains ideally should not be touched, but if required and if you touch the gains is only to, remember, it is only to improve the visibility, it is not to improve the resolution. Doesn't improve the image quality, on the contrary deteriorates it because too bright and too dark. Both the images would give you fall or deterioration in the soft tissue details. So once your gains are adjusted, please don't keep on changing it. But if at all you still have to, after doing all the other adjustments that I talked about, if you still have to, that is when you may change the gains, you may examine the structure that you want to, but the moment you move out of that scanning phase, again go back to your preset. Because when you do a gynec scan, you are looking at cystic lesions which appear very similar to each other. Say for example, a follicle, a luteinized unruptured follicle, a corpus luteum. And if your gains are not correct, a corpus luteum will look like a follicle and a follicle may look like a luteinized unruptured follicle. So be very careful, don't keep on changing the gains. Having done that, now we move to the color things. And for the color, I think the basics, most of you know, or if I need to tell you in very short, color Doppler, where you see two colors, you are seeing two colors because it tells you the direction of the flow. The flow which is towards the probe usually appears red, flow which is away from the probe usually appears blue, but you can invert it. So don't always get carried away. Moreover, when you are doing your gynec and infertility scans, direction of the flow is not important to you. Most of the times you are looking at the capillary networks. You are not looking at single large vessels except when you are looking at the uteri. So don't worry about the direction. Just remember they indicate two different directions of the blood flow, red towards the probe, blue away from the probe. If that is the case, the flow which is perpendicular to the sound beam, it is not towards, it's not away, will not be shown on your color Doppler. It will not be shown on the color Doppler, though it is there. It is therefore that we need power Doppler. Power Doppler is a non-directional Doppler. Yes, it is true that as the name indicates power Doppler, it actually potentiates the Doppler effect of the sound wave. Let's not go into the physics. But it actually makes low velocity vessels visible. It makes low velocity vessels visible. And it doesn't tell you about the direction. So even the blood flow which is perpendicular to the sound wave will be seen clearly. So that is the practical application for the power Doppler. But now we also have what is called HD flow. HD flow is again a high resolution flow, but it also can show the directions, as you can see here. And the last thing is the spectral Doppler, is the graph that you get for the flow. That is called the spectral Doppler. That shows you the direction also. That tells you what is the exact quantity of the flow also. The other two Doppler only tells you about the flow, it tells you about the quantity of the flow only subjectively. That means that the color which is brighter is high velocity, color which is darker is low velocity. It doesn't give you exact numbers. Spectral Doppler gives you exact numbers. Now coming to the color Doppler settings, the first thing is the gains. And remember that when the settings are done by the application specialist, even when you are doing your low velocity flow assessment, endometrium or the follicle, there should be no color spill outside the vessels. This is color spill outside the vessels. The gains, if this is the result, the gains should be decreased so that the color is contained inside the vessels fully. But if you decrease the gains further, you will not even see these vessels. If you decrease the gains further, you will not even see this vessel. See? Yes, so the gains have to be correctly set so that you see the vessels completely filled, no spill, but filling up the vessels completely. The second important setting is what is called PRF setting. And PRF is what? Pulse repetition frequency, or it may be scale on some of the machines. PRF should always be, I will not go into the physics again, PRF should be always related to the velocity. For high velocity flows, you need high PRF. For low velocity flow, you need low PRF. If you use high PRF for low velocity, though the flow is present, you will not see it. And if you are using low PRF for high velocity, that is when you will get mixing of colors or overlapping of the spectrum, which is called aliasing, okay? So remember that the PRF must be set in a way that your diastolic flow, if you are seeing large vessels, the diastolic flow has to be unicolor. If you try the systolic flow to be unicolor, the diastolic flow will not be recorded. So that is how your PRF should be adjusted, but you don't have to use your abilities and brains here. You don't have to do any efforts here, because for all our infertility scans, as a rule, the PRF is set at 0.3. If you get flow at 0.3 PRF, fine. If you don't get flow, forget about it. Don't decrease the PRF. Similarly, gains, once they are set, are not to be changed for any of your infertility scans. For Gynae scans, the PRF is to be fixed between 0.3 and 0.6. You should not keep on changing it, because if you keep on changing it, you will never be able to compare one examination with the other. The third thing is what is called wall motion filter. What is wall motion filter? Many a times when you switch on the color, you will have color and you will have white dots on it, what we call snow on the color. Have you seen that ever? Oh, sorry. Sorry, I'm sorry. I was talking of balance. So what will happen is, see, you are seeing snow on the color, you are seeing that snow on the color, and now the color has disappeared. You are seeing it? This is normal, see, this is normal color. And this is snow on the color, this is snow on the color. Can you find out? Can you find the difference? Yes? So when you get overlapping of soft tissue details or snow on the color, that is when practical solution is to decrease the 2D gains. Don't touch the color gains, don't increase the color gains, decrease the 2D gains. And as soon as you decrease the 2D gains, you can see here, as soon as you decrease the 2D gains, increasing 2D gains and you are getting snow, and now decreasing 2D gains and you will see beautiful color. So that is the practical solution, but actually that is what is called a balance setting. I will not go into the details of the balance setting here, but there is one green line here seen on the grey bar which works as a balance setting. If you want explanation on that, I will talk in the questions and answers. Coming to the last one, and that is a wall motion filter. We know that every moving object to which a sound beam hits creates change in the frequency of the incident beam and the returning beam. This effect is called a Doppler effect. The Doppler effect reflects as color there, and the higher the velocity of the vessel, higher, that is what we talked about already, higher the vessel, higher is the Doppler, higher the velocity, higher is the Doppler effect, and higher is the Doppler effect, brighter is the color. Yes? Lower the color, lower the velocity, lesser the Doppler effect, and dull will be the color. But those things, they also lead to unnecessary additional information on the image. You get color with the flow, you get the color with the moving vessel wall, you get the color because of the transmitted pulsations also. Yes, but you don't want the information of the wall movement, you don't want the information of the transmitted pulsations, and therefore if you put a filter which will filter out low intensity color flow, which is called wall motion filter, so that is also always put at the lowest. If that is also high, you will not document any low velocity flows. So there are a four basic settings that you will require for the color and the power. When you are looking at the spectrum, you know this is the baseline. In 5 minutes we will go for the live demos. So whoever wants to make some arrangements there. You have a baseline, you have the flow which is above is towards, the flow which is below is away from the probe. The spiky flow is the arterial flow, the flat flow is the venous flow. On the arterial flow, this is systolic, this is the diastolic phase. This is the peak systolic velocity, this is the end diastolic velocity. Wherever the diastolic flow is more than 50% of the systolic flow, as you are seeing here, this is called a low resistance flow, where the systolic flow is more than 3 times the diastolic flow, more than 2 or 3 times the diastolic flow. We call it a high resistance flow. What are the settings important here? Your color the spectrum of the flow should always appear nice and bright like that, bold and clear. If your gains are more, you may have a lot of extra information, which is because of high gains. So whenever you get, it will come in a minute. I'll tell you this is wall filter, but let us see if it has also gains here. Yeah, this probably has gains. Yeah, so if you get a picture like this, that means you have to decrease the gains. But if you decrease the gains too much, you will not get any information at all. This is low gains, that was high gains. So the gain should be set in such a way that you get a nice bold spectrum. The second important setting again is the wall filter there. As I told you, the wall filter filters out low velocity information, and therefore if you get a black line between the baseline and the spectrum, which should tell you that yes, the wall filter is high because the low velocity flows are not documented, this spectrum is never ever to be accepted, even if it is from a close friend, because that will give you a false impression that there is no diastolic flow. Actually, it is a high wall filter. So remember, the correct wall filter setting is that always the spectrum must touch the baseline, only that is acceptable. The third important thing would be PRF. Again there also, as I told you earlier, for high velocity flow you need a high PRF. What is the correct PRF setting? When the systolic peak covers at least 1/2 to 2/3 of the area dedicated for the spectrum. So if the peak is this high, I would be happy. But if I increase the PRF too much, not here, I don't know if I have that, I'll show you on the light. So if your PRF is too much, even the high velocity flows will not be seen. The high velocity flows are not seen, the diastolic flows will be seen very little. Therefore, you will lose the differentiation between the systolic and diastolic. So it must be always adjusted so that you can see the systole and the diastole clearly. So those are the basic settings that we would require, and we will shift over to the live demos. If there are any questions, you can ask me now. You can ask me in lunch. You can also ask me when I'm doing live demos, okay? Should I take the same mic there or there's a different mic there? There's a different mic there?
Yeah, there is a different mic there.
Yes, ma'am, I know you very well. When I enlisted for this course. Yes, Bhopal. Yes, I know you very well. Yeah. So, my question is, while viewing for left ovary, it's always while doing the TPS, viewing the right ovary is a bit better, but sometimes it is very difficult to view the left ovary to come into the center.
It is usually not difficult. I mean, you are right. This is a very common complaint, but it will not be difficult if your probe movements can be easy. It is chiefly because when we are seeing the right ovary, we have a lot of space to move the probe onto that side, but we cannot move the probe too much onto our side. Therefore, the left ovary is right-handed or left-handed is not a problem, but there is no space to move the probe. So that is why the correct the correct examination table is required. That's why I said that deep curve there.
Another question is, if the patient is multiparasomel, at that time also fixing the uterus in the center is very difficult.
So it is in these cases that it's not because of anything else, it's because of the severe muscle laxity. So ask your assistant or a person to just limit the movement of the uterus or the ovaries by making sort of a wall. So don't ask her to press down, ask her to press vertically so that the organs will not slide up.
সবাই একটু ধৈর্য ধরে বসেন, এখনই আমাদের লাইভ ডেমনস্ট্রেশন শুরু হবে। আমরা আসলে কাজের সুবিধার্থে কয়েকটা গ্রুপে ভাগ করে নিয়েছি। যারা ফার্স্ট গ্রুপে আছেন তাদের নাম এখন ডক্টর জেবুন বলবে। তারা আমাদের এই পাশেই কল্পস্কোপি রুমেই আসলে আমাদের এই ডেমনস্ট্রেশনটা চলতে থাকে, আর আমরা এখানে স্ক্রিনে দেখব।
গ্রুপ পেতে যারা আছে এখন ওরা চলে যাবেন আমাদের কল্পস্কোপি রুমে।
এটা ongoing একসাথে চলবে। প্রফেসর শাহেনা আক্তার, প্রফেসর শিরিন আক্তার, ডক্টর আফরোজা ফেরদৌস, ডক্টর রওশন আক্তার জাহান, ডক্টর জেবুন্নেসা, ডক্টর আসিফ আলী, ডক্টর ফাহমিদা শিরিন, ডক্টর বনিতা বিশ্বাস, ডক্টর সাবিহা কাদের, ডক্টর ফাহমিদা ইসলাম চৌধুরী, ডক্টর সাইয়েদা ইয়াসমিন আক্তার, ডক্টর নূরজাহান বিদ্যে সাইদ, ডক্টর এলাকি সুনন্দা সেন, ডক্টর কামরুন নাহার, ডক্টর জাস্টিন ক্যাম্প আর ডক্টর নার্গিস। সবাই আমরা এখন ইয়েতে চলে যাবো 31-এ কল্পোস্কোপি রুমে। এই গ্রুপের যাদের নাম আমি ঘোষণা করলাম।
এখানে আসলে 1.5 ঘন্টা লাইভ ডেমনস্ট্রেশনের মধ্যে 25 মিনিট সব গ্রুপে যারা পাবে, আর প্ল্যানারি এখান থেকে সব দেখা যাবে। ঠিক আছে, আর সোনোলজিস্ট যাদেরকে গ্রুপে ভাগ করা হয়েছে তারা ওইভাবে ম্যাডামের সাথে ওখানে দেখতে পাবে।
সাধারণত এই প্রোগ্রামগুলি ঢাকাতেই হয়, ঢাকার বাইরে খুব একটা হয় না। আমরা অত্যন্ত ভাগ্যবান যে এটা 3rd টাইম আমরা যে চিটগং মেডিকেল কলেজে এই প্রোগ্রামটা করতে পেরেছি, এবং এটার জন্য অ্যাসাইন আসলে 25 জন ডক্টর। কিন্তু আমাদের মনে হয়েছে যে এই সুযোগটা আমরা সকলেই উপভোগ করি, এই জন্য আসলে ওজিএসপি এবং ট্রেনি যাদেরকে আছে তাদেরকে আমরা ইনক্লুড করার চেষ্টা করেছি। আপনারা আমাদের এই ডাকে সাড়া দিয়েছেন, এই জন্য আপনাদেরকে ধন্যবাদ জানাচ্ছি। যারাদের সরকারিভাবে নাম আছে আসলে তাদেরকে আমরা ওখানে হ্যান্ডসন একটু নিতে হচ্ছে, আর আপনারা এখানে আছেন এই জন্য এটা মনে করার কোনো কারণ নাই যে ওদেরকে এক্সট্রা বেনিফিট দেওয়ার জন্য নিয়ে যাচ্ছে। ওরা আসলে সরকারিভাবেই অ্যাসাইন এই ট্রেনিংটা করার জন্য, যারা এখন ওখানে হ্যান্ডসনে গেছে। তারপরে এখানে আপনাদের একটু অসুবিধা হচ্ছে, এটার জন্য আমি দুঃখ প্রকাশ করছি। তবে আপনাদের কোঅপারেশন এবং ডেডিকেশন আমাদের প্রোগ্রামটাকে সাকসেসফুল করবে। আমাদের কিছুক্ষণের ভিতরেই লাইভ ডেমনস্ট্রেশন শুরু হবে। এর ভিতরে আমাদের সাথে শাহনাজ চৌধুরী ম্যাডাম আছেন। কারো যদি কোনো প্রশ্ন থাকে ম্যাডামকে জিজ্ঞেস করতে পারেন। ম্যাডাম ইনফার্টিলিটির উপরে মাস্টার্স ডিগ্রি করেছেন। আমরা সবাই জানি যে টিবিএসটা ইনফার্টিলিটির সাথে ক্লোজলি রিলেটেড। অতএব এই রিলেটেড কোনো প্রশ্ন থাকলে লাইভ ডেমনস্ট্রেশন শুরু হয়ে যেতে শাহনাপা আছে আমাদের সাথে। সনোগ্রাফি 2 জন স্পেশালিস্ট আছে, প্রফেসর আনিসুল মাওলা এবং প্রফেসর দিদারুল আলম। এর ভিতরে আপনারা কোনো প্রশ্ন থাকলে ওনাদেরকে করতে পারেন।
So there is already flow in the 10th day of the cycle stage. But remember one thing, the day of the cycle is not at all important. What is important is its synchrony with the follicle. If whatever the day of the cycle, if the follicle is grown, only then the endometrium is going to grow. There is no relationship between the day of the cycle. In the PCO patients, we have seen that even in the natural course, they would have a pregnancy, even if they are getting periods at 45 days or 60 days. Do you think they ovulate on 14th day? They don't, right? So, and in no physiology book is the length of the proliferative phase fixed. The length of the proliferative phase is not fixed. It is only the length of the secretory phase which is fixed. So, proliferative phase can be any long. Now, doesn't matter. What is important is whether the follicular growth correlates with the endometrial growth or not. And in this case, where you said the endometrium, you only said, right? Who said? I think it was you said the last time the endometrium was thin. Yes, so if you see that the follicle has grown to beyond 18 and it also shows flows and still the endometrium is not going, only then it should be of a concern, because here you can see that even with that 10 endometrium, you have started seeing the flows in the endometrium already. That means that the endometrium is, is growing, and anything more than 6 should be fine. So 5 millimeters on day 30, but third day doesn't matter. As I told you again, look at the follicle. The follicle grows beyond 18 and shows good flows, and still the endometrium is not there. Only then it is a concern. Most likely here, if you wait for either a good quality follicle, or you develop a instead of a monofollicular, a bifollicular development, you will get a good endometrium. Endometrium otherwise looks very healthy in this. We will discuss that with the presentation. But yes, if it is an IUI cycle, only the dominant follicle. If it's an IVF cycle, you need to measure all the follicles. But again, what is dominant follicle is also that requires more explanation. Can somebody please tell me the history of this patient? Hello? Can anybody please tell me the history of this patient?
গ্রুপ সির পার্টিসিপেন্টের নাম ঘোষণা করা হচ্ছে, ওরা ওই রুমে যাবে, হ্যান্ডসনে যাবে।
So basically she is a primary infertility patient.
ডক্টর আইনুল্লাহ হামিদ,
primary infertility patient with irregular menstrual cycles. Menstrual cycles are regular only with medicines. If they are regular with medicines, that means we only consider it as irregular. Otherwise, that means she is only getting withdrawal bleeds. Okay? We are starting with the scan. And we have uterus, which probably is retrograde duplex. Again, I am not seeing any uterus in the midline. Spanning the probe onto the right side, the uterus is right onto the right side. It is absolutely, just 1 minute, madam. So there is nothing here. So the report comes to follicle of 21 and 24 in the right ovary. The follicle of 24 does show fairly good flow. Endometrium morphology is grade A to B, and the uterine artery flow is normal, so we can go ahead with the trigger. Yes, madam, tell me your question, please.
No, madam, the audience has to see the endometrial morphology.
Endometrial morphology. Oh, there is a small polyp there, probably. There is a small polyp there, probably.
And can you see the measurement of the polyp?
The polyp is small, madam, but whatever it is in the lower segment, so it is not of significance at all.
Not hamper the implantation?
No, it will not come in the way of implantation at all.
Is this produce a difficulty during the IUI?
No, madam, no, it will not.
And you see the uterocervical canal.
The cervical canal is beautiful, madam. No issues at all. It's just superb.
Audience follow the
Sorry, ma'am?
No, I see the audience whether they can follow you or not.
Yes. See, the cervical canal is nice. Yes? The endometrium is also nice. That polyp, if at all it is in the lower segment. It is not going to come in the way of any implantation at all. Okay? So I don't think we need to worry about that at all.
Now, madam, sometimes when we are going to do your IUI, then at the time the cervical negotiation is difficult.
No, madam. In this case, it will not come in the way because more than half of the cavity is empty. That doesn't matter at all. So that is not going to be the problem. I think this can be, there is a good chance that this can be a fruitful cycle if the IUI is done. Trigger and IUI. Day doesn't matter. I repeat again, day doesn't matter. Yes. And the follicle is already 24, you cannot wait beyond that.
Hello?
Yes, ma'am?
Can you explain why the date is not important?
The day is not important because there is no fixed length of the proliferative phase mentioned anywhere in the physiology, ma'am.
And that
So
is the
there
random selection.
There can the length of the proliferative phase can be anything. If at all, what is important is once the dominance of the follicle is selected, its growth rate should be 2 millimeters a day. The selection of the dominance in a low reserve patient where the AMH is low, where the FSH is high, there may be early recruitment of the follicle, and the follicle dominance can be selected as early as day 3 maybe, and in that case the follicle may grow to maturity on day 8 or 9, and you can, if the follicle is good in quality, you can do an immediate, you can do give a trigger and do an IUI, and the results are very good. In the PCOS patients, as I was telling earlier also, we see so many PCOS patients who have irregular cycles, but they do conceive naturally. Why? Because in those patients, the dominance of the follicle is selected late, but once it is selected, then it has to grow at a rate of 2 millimeters. So that is what is important, and then it has to synchronize with the endometrium. If we think that because it is day 20 or 21, the endometrium will turn secretory, it doesn't turn secretory because endometrium is nothing but just a receptor organ to estrogen and progesterone. It doesn't have its own mechanism. And therefore, unless the estrogen or progesterone are secreted, the endometrium is not going to grow. So with estrogen, the endometrium will grow. When the estrogen level rises to beyond physiological, so truly supraphysiological levels, or for some reason LH is high, only then the progesterone secretion will start and there will be endometrial embarrassment. In the routine course, that doesn't happen.
বুঝা গেছে কি বলছে উনি? হ্যালো, বুঝা গেছে? আমরা অনেক সময় দেখি কি আমাদের
Yes, of course. You can trigger it on 40th day. We do IUIs on 40th day, 45th day, whenever the follicle matures. Doesn't it? On my side, a little on my side. A little down.
আর পলিসিস্টিক হলে দেখা যায় কি লেট ফলিকুল গুলো লেট ম্যাচুরেশন আর বলছি 2 mm পার ডে ফলিকুলার গ্রোথ
This is a baseline scan.
Madam,
she is bleeding.
Madam, I have a question.
Okay. She is bleeding. Yes.
Madam, Dr. Sonal Panchal.
Yes, ma'am. Yes.
I am Dr. Porak, your trainee also. And 2010 I did Transvaginal Sonography from you, from Ahmedabad. Ma'am, I have a question. Previously you said that there is a small polyp, not below the fundus and at the midline, that patient. This polyp may hamper to the embryo transfer?
No, madam, it will not come in the way.
Yeah, no need to go for the any hysteroscopic evaluation.
Nothing to be done for her.
Okay, okay, and also another question is there. I have
because I put the flow and there was a single feeder vessel, nothing else there, so nothing to do for that.
Okay, okay. And another one is the in case of IUI, if there is follicle matures even 21 days or 22 days, I have seen you say
even if it is 40th day, I will not mind.
Okay, and trigger, I have also the 19-day trigger was given and that patient was pregnant by IUI.
Yes.
So I know that. Okay, thank you.
The bladder is full. The bladder is full and there is a difficulty in seeing the scan, but if you can see it, you will do it, otherwise we will send out. Okay? So here, beautifully, that will include the baseline scan. Baseline scan I have shown you, but we will do a little more detail on that. We have to do the pre-trigger scan, how to decide for the trigger for IUI and IVF cycles. IUI and IVF cycles, and we will also assess the luteal phase scan, and I will tell you why luteal phase scan is essential. And then we have to also do, I don't know how much we will be able to, but I will try my level best. We also have to do early pregnancy. And we also have to do endometrial lesions. So let us see how much we can. I will try to do my best, but I don't want to give you just a bird's eye view of everything. Whatever you learn, you should learn in detail. You learn one topic less would be okay for me, but if you learn just superficial which you cannot apply is not okay for me. Okay, you all agree with that?
Yes.
So let's start first with a pre-trigger scan, because that is what appears like more interesting and more clinically oriented. I know you might all be a bit tired with the live demos. I don't know how it was. Though it was, let me tell you very frankly that the colors can be much better than this. Of course, I don't say the machine is bad, but they need to do a lot more setting on this to see the colors better. And what you are seeing on my presentation, the way you are seeing the colors on my presentation, you would realize that they give you much more clear information than what we were seeing today. But it is not necessary that for that you need very high quality machines. It is also a good color Doppler that can give that. A good color Doppler and good settings would be hello? 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 Audible? Audible, yes? So anything that is good, I mean a good color Doppler machine would definitely show everything well. Yes, I know the cost is a factor for everybody. It's a important factor to be considered for you. It's an important factor to be considered for me also. But you can do much better Dopplers than what we saw today. Just a little better machine setting is what is required. So starting with a pre-trigger scan, the follicular and the endometrial tracking. Now when I say follicular and endometrial tracking, generally the impression is the follicle 16 or 18 millimeters, is the endometrium 7-8 millimeter triple line? I am going to give a triple for that. And that single scan has no meaning at all, because if you want to know whether a boy or a girl, before you select them for the marriage, you would see how they have been brought up, what is the family like, and only then you would know, and not just a picture of him or her. That means you need to know how it has, how that person has been grown up and brought up, to know that what would be the true profile of that person. Similarly, for the follicle and the endometrium, it is essential to follow the follicle right from the time the dominance of the follicle is selected, and we know that the dominance of the follicle is usually selected at about day 5 in a normal length cycle. The older study says that you can assess the dominance or you can document the dominance on ultrasound on about day 7. But I probably don't believe this with all the new very high quality ultrasound scanners. The day the dominance is selected, we can definitely evaluate, we can definitely document it. But what is dominance? Is something very important to understand. Dominance, is it just the size? Is the size the dominance? No, I don't quite agree with that. Just excuse me, I'm going to change this presentation to another one, which probably I am more happy with. Is just the size dominance? No. Dominance is the sensitivity of the follicle to FSH. And remember that in the reproductive system, at least I know that any organ or a structure would get sensitized to that biochemical or that hormone only when it is exposed to that biochemical. That means that if the FSH receptors have to develop in the follicle, FSH has to reach the follicle. and only then the receptors will develop, and only then the dominance is selected. That means that if I want to truly confirm the dominance of the follicle, I must be able to see the blood flows. I think this is not consistent. Hello? Now it is okay, but it has to remain steady, okay? So, what is important is that you should be able to see the you should be able to see the flow of the details. If you say Cooridinator, if you know that, I mean, if therefore whenever you see a follicle which has reached 8, 9, 10 millimeters, it is very essential that you would switch on the Doppler. And see, many times it happens that you are doing a day 2, 3, 4, 5 scan. You will see a follicle which appears like 10, 11, 12 millimeters in size. And there may be 2, 3, 4 such follicles. So you are most of the times confused. There is multifollicular development. And many of you may also be thinking that this patient should not be taken for IUI. Let us take her for IVF. It is very important to understand that the follicle, as soon as it achieves its dominance, it is going to show you flow surrounding the follicle. And if you want to see it live, see this follicle which appears quite large, but it does not show any flow. If you say this is perifollicular flow, I don't agree with you, because remember, only the blood vessels which overlap on the follicular wall are perifollicular flow. The rest is not. So this follicle to me has no flow at all. This is another follicle by the side of it, but that also has hardly any flow. So even if you say it is just a bit of it which is touching that follicle, not really. Just let it be back down. No, I'll show you. So that is. So that is also not good. Forget all this. Just let it out. Let it be out. Don't come in between. Just leave. So that is also not a mature follicle. But if you go ahead, that is when you are seeing 1/3 follicle, and look, the entire hilar flow is being directed towards that follicle. Can you see that? And it shows a beautiful ring of color surrounding, which tells you, yes, this is definitely a dominant follicle. And this is one special mechanism by which the human physiology, normal human physiology of a single pregnancy is being maintained. Because this flow, the entire flow, because it is directed towards one single follicle, therefore the follicles which are in the close vicinity of this follicle also stop growing, they regress, and therefore only single follicular maturation and a single pregnancy is a normal physiology in a human being. That means we know that follicle which has reached 8, 9 millimeters in size, beyond that you are going to check the blood flows, and only if the blood flows are present, only then the follicle is a dominant follicle. And if the follicle is a dominant follicle, because it has already developed sensitivity to FSH, it is going to grow at a rate of 2 millimeters, about 2 millimeters a day. There are different studies, they say 2 to 3 millimeters. There is one study which also says 1 to 4 millimeters, but usually 2 to 3 millimeters, even 3 millimeters is a little too much for the growth of a follicle. And then we all know that when the follicle reaches about 18 to 24 millimeter in size, that's when it's going to ovulate. If therefore I am doing a monitoring and I am asked as to how often, the patient asks me how often do I have to come for my scans. This is often a question, especially for the working ladies. And then the schedule goes this way. If you are doing an IUI cycle, and if it is a oral ovulogen cycle, that means you are going to give only CC or you are going to give letrozole only, then you can call the patient for the first time only when it is the last dose of oral ovulogen. So if you are going to give CC, usually we give CC from day 5 day 5, 6, 7, 8, 9. And if it is letrozole, we would prefer to give it day 3, 4, 5, 6, 7. So with letrozole cycle, the first visit will be day 7. With the CC cycle, the first visit will be day 9. On that day, when you do a scan, if all the follicles are still smaller than 10 millimeters and there is no dominant follicle, that does not mean that patient has not responded. The dose that you have given is going to act and the patient may develop follicle a little later. And if there is no dominant follicle, call her directly after 5 days. But if there is already a dominant follicle, calculate when you expect the follicle to reach 18-19 millimeters in size and accordingly call the patient. Say for example, today is the last day of oral ovulation. I see the size of the follicle is 13, tomorrow 15, day after 17, day after then 19, that's when I'll call the patient. You understand? So that's how the oral ovulation cycle monitoring is done. But whether it is oral ovulation cycle or it is a gonadotrophic cycle, once the follicle reaches a size of 18-19 millimeters, beyond that you are going to call the patient every day to check the flows till you get optimum parameters to give a trigger. If it is a gonadotrophin cycle, and the best stimulation protocol would be when you can, for IUI would be letrozole plus gonadotrophin. Of course, gonadotrophin alone also gives excellent results, but when you give letrozole plus gonadotrophin, that is when you can cut down the cost of gonadotrophin and still not compromise with the results. Remember that when you give CC with gonadotrophins, the advantage of gonadotrophins is gone. Why? Because when you give CC, the LH is already high, and after that if you are going to add FSH, the ill effect of LH is still going to be there, and therefore the results will be just as good as CC. But if you give letrozole plus gonadotrophin, the results would be as good as only gonadotrophins. So that is how letrozole plus gonadotrophin is one of the best protocols, or you can give only gonadotrophins also. But if you are doing a gonadotrophin IUI cycle, the first scan is done on the day when you give the first gonadotrophin. When you give the first gonadotrophin, on that day, if all the follicles are still smaller than 10 millimeters, directly call them after 5 days. But if there is already a dominant follicle, as told earlier, calculate when the follicle is likely to reach 18-19 millimeters and accordingly call the patient. Yes, we are clear about the number of visits. Now, going to measuring the size of the follicle, since I have already shown you on the live, longest diameter perpendicular to the long diameter, and the transverse diameter is the widest diameter parallel to the x-axis, and the mean of that is your mean follicular diameter. Remember, there is no point giving follicular size as 2 diameters. I am writing 14 by 16, 12 by 15, doesn't make any sense to me. Why? Because it depends on the third diameter what would be the actual size of the follicle. Say for example, I am seeing 14 by 16, 14 by 16 by 20 is a different size, 14 by 16 by 12 is a different size. So it is very important that you write all the 3 diameters and the mean of that. That is the correct size of the follicle. But if the follicle is not oval, it is absolutely spherical, then so you rotate the probe and still it is the same shape. That is when you can take only 1 diameter, and that diameter is an AP diameter and not a side-to-side diameter. Okay? Why? Because from these 2 walls, the sound beam reflects completely. So these 2 margins are always much more sharper than these 2 margins. So your measurement is more precise. So that is about measuring the size of the follicle with 2D ultrasound. Now, apart from that, you also need to see that the follicle appears nice and high and echoic contents. It has thin walls which are isoechoic to the stroma, and the shape is round or oval. And these are the findings which tell you, yes, this follicle generally appears okay in quality. It is about 24 to 36 hours before the ovulation that you would start seeing a hypoechoic line, and this is a sign that the ovulation may be occurring within next 24 to 36 hours. And sometimes you may also see a tiny solid projection arising from the wall of the follicle, which is probably a cumulus. Why did I say probably a cumulus? Because sometimes it does happen that there may be a small follicle by the side of this larger follicle, and the wall of this follicle may appear like a shelf. So if you rotate the probe, once you see this cumulus-like structure, if you rotate the probe and you see that this solid projection either remains as such or it disappears, if you have changed the plane by chance, it disappears, it may be a cumulus, but if it elongates or if it walks with the rotation of the probe or movement of the probe, it is not a cumulus, it is probably a wall of the neighboring follicle. But there is one thing which is, of course, yes, cumulus is one of the surest signs to tell you that the follicle contains a fertilizable oocyte, but since it is a very tiny structure, you need to zoom the follicle well, and you need to scroll across the follicle in the longitudinal and in the transverse plane, and only then if you see this, you still see this cumulus, you know that it's a cumulus. So therefore, the literature says yes, follicles beyond 15 millimeter are likely to show you cumulus, but if you are using only 2D ultrasound, the chances that you would see the cumulus is only about 30 to 35%, but if you can see a 3D, then the cumulus would be seen in more than about 85% of mature follicles. Since it is not very commonly seen or being able to locate in every mature follicle, therefore, yes, if you see it is a positive sign, but it is not a mandatory sign before you give a trigger. But it is that also which tells you that ovulation may occur within 24 to 36 hours. It's very important to understand here that many a times you may see a follicle and you will see a crescent-like structure inside, which people say, was it there? I don't know. So if that is there, people say this is a cumulus. This is not a cumulus. Cumulus is a cell mass. It has to be solid. If it's a crescent-like structure, it is only a neighboring follicle. It's only a small follicles by the side of that large follicle, and it is not a cumulus. It is about 6 to 10 hours before ovulation that you would start seeing low-level echogenicities inside the follicle. And it is around the same time that you will also see niche-like triangular lesions or breaks in the wall of the follicle, which is called a rose-bush thorn sign. So low-level internal echogenicities and this niche-like projections tell you that the ovulation is truly impending. Why are these low-level echogenicities seen? Is because you know that the cumulus oophorus complex is secured in the follicular wall under a cell layer. It is just before the ovulation that this cell layer separates and the cumulus is released inside the follicular fluid. When the follicle matures, gradually the follicle has surfaced onto the ovarian surface, and from the surface from where the ovulation is going to occur, that part of the follicular wall bulges a little out of the ovarian wall, and because it bulges out, it gets thinned out. The vessels regress from there, so it also becomes avascular, therefore more fragile. When the follicle is mature, that's when the the fibria of the tube come and overlie on that part of the ovary. There is ciliary movement which occur in the tube, which leads to negative pressure. It is because of this negative pressure that the fibrillar gland, which is covering on the thin part of the follicle, that membrane ruptures and it sucks all the fluid into the tube, along with which the cumulus also goes to the tube. So that is why when we were doing demos, I think twice or thrice did I say that it's not just the tubal patency that is important, it's the tube-ovarian relationship which is important. And unless the tubes are close to the ovaries, they will not be able to pick up the ovum that is released with the ovulation. But there is something very important that I want to tell you here. I will require a mic. I cannot stand and talk. Oh, hand wala mic. देखो ना अगर हो सकता है तो please. So, and what is that fact? The fact is that if all the fluid has been taken up by the tube, so if the fimbrial end is well opposed on the anything which is working. So if you see that if the fimbrial end of the tube completely covers onto the ovulation site, no fluid will leak outside. And if no fluid will leak outside, I am confident that the fimulus is inside only. Fertilization is going to occur. Or it is likely if everything else is fine. But if there is fluid in the pouch of Douglas, which most of us believe is a sign of ovulation, I am not happy with it, because I would believe that it is possible that if some fluid is leaked out, the ovum might have also leaked out. So, very important to understand that free fluid is not, presence of free fluid doesn't tell you anything. Doesn't tell you anything also because there would be free fluid present even in absence of ovulation if the estrogen level is high. That means presence of free fluid doesn't tell you ovulation has occurred, absence of free fluid doesn't tell you ovulation has not occurred. What does tell me when the ovulation has occurred? The follicle which was growing starts showing internal echogenicities in form of hemorrhagic echogenicities, fishnet appearance, honeycomb appearance, fibrin strands, or it is completely collapsed. One of the two things tells me yes, ovulation has occurred. Yes, so that was just one side talk which I could have avoided, but I thought it is interesting and that's why I told you. So that means that your 2D ultrasound tells you ovulation is going to occur, but it doesn't tell you anything about the quality of the follicle. The quality of the follicle can only be assessed by the Doppler, and the blood flow that has started developing with the dominance of the follicle keeps on increasing and grows to cover at least 2/3 to 3/4 of the follicular circumference. And it is 2 days before ovulation, 48 hours before ovulation, that you will see that the RI of these vessels, they go below 0.5. This is the same time when the final estrogen surge comes, and therefore the fall in the perifollicular RI tells me that there is a final estrogen surge, and it also tells me that the estrogen level is adequate. That also means that the follicle quality is adequate. It is beyond that time that the PSP of the follicle starts rising, and when the PSP of the follicle reaches 10 centimeters per second, this is the time when the LH surge is going to start. That means perifollicular pre-ovulatory PSV correlates with the LH. So if the follicle has vascularity covering at least 2/3, preferably 3/4 of the circumference, and it shows RI of less than 0.5, and it also shows an PSV of more than 10 centimeters per second, yes, this is the time when, if it is a natural cycle or it is an oral ovulation cycle, the surge will start. And if I am going to do IUI, I will give a trigger because I need to time the IUI. But if I am not going to do an IUI, if I am not even giving her a timed intercourse, that is when I don't need to do anything. I do a follow-up, and with these parameters, LH surge has to start, and within 2 or 3 days you will see the ovulation occur. But if it is a gonadotrophin cycle, then it is very important to understand that because you are giving exogenous gonadotrophins, therefore the endogenous hypothalamo-pituitary ovarian axis, the control of the gonadotrophin, it becomes very lazy. It may start the LH surge, but there is a high possibility that this LH surge may be inadequate or the surge may not occur at all. And therefore, whenever you are giving gonadotrophin, trigger is a must. So why do we need to evaluate this flows? It is because, as I told you earlier, it tells me about the functional maturity. What is that functional maturity? Yes, if I have seen this, the flows on Doppler in the follicles, the perifollicular flow, that means that if I give a trigger and if I do a pickup, I am going to get oocytes from those follicles. Not only that, even if I have not seen the flow and I do get oocytes, but those oocytes have a high chance of chromosomal abnormalities because of segregation disorders, and that would lead to catastrophic mosaics in the resulting embryos also. Another study also says that if the PSV of the follicle is less than 10 centimeters per second, the chances that you would get grade 1 embryos out of these oocytes is very little. It is therefore that it is very essential to check the RI and the PSV of the follicle in the decision making. I will just as a little sidetracking, I know, but I need to tell you this, and that is this study which I have quoted here is 30 years old, 27 years old. It dates back to 1996. And even that, then, if it is, the study writes that if the PSV is more than 10 centimeters per second, the chances of pregnancy is as high as 70%. If it is less than 10, it is 40%. If there is no flow at all, it is only 24%. But in this 30 years, we all know that the Doppler sensitivity has increased tremendously. And if that study was done today, I would say that the last sentence would have been only 5 to 7%. So if there's no flow, the chances that you can get a good quality embryo out of that oocyte is as low as about 5 to 7%, not more than that. Not only that, I also want to request, the director Saab is not here, but I wanted to request him that please plan for a Doppler, because that will improve the results in majority of the people, because you can get a pregnancy with only IUI. You don't need to do IVF in majority of the patients. That is not a help to doctors alone, that's a huge help to the community. So if anybody can, Principal Madam can, please convey my message to the director sir to get at least a Doppler, I'm not saying a 3D, 4D machine, but at least a good Doppler that can improve your results significantly. Coming to the next point, and that is, yes, if the vascularity is more naturally, the follicle is producing more estrogen, because more vascularity, more receptors to FSH, more estrogen secretion, it will ultimately lead to a timely LH surge. So if at all you can, so if I said that the vascularity has to cover at least 2/3, preferably 3/4 of the circumference, you either, if you are using only a 2D and a Doppler, you have to switch on the Doppler and then gently scroll across the entire follicle in one plane, in the another plane, so longitudinal plane and the transverse plane, and eyeball and evaluate how much of the follicle is vascularized. Of course, if you have a 3D, you have a boon, you have a luxury, and you can beautifully see this vascularity. But remember, better the vascularity, better is the estrogen secretion, and better is the quality of the follicle. I will not include anything about 3D here because probably it is untimely to do that. But let us go and see this. So this is about the IUI cycle. Now what about the IVF cycles? When it is an IVF cycle, yes, it is true that in IUI cycle sometimes you may get multiple follicles, but if you follow the baseline score that I am going to tell you, you will never have multifollicular development. Even with antral follicle count of 45 to 60, we have developed only 1 or 2 follicles in these females, even with gonadotropin stimulation, following these protocols. So most of the times in IUI, you are not going to develop multiple follicles, but by chance you have produced multiple follicles in IUI, or when you are doing IVF where you opt for multiple follicles, that is when all the follicles are compressed by each other. You can see they are all compressed by each other. Because they are compressed by each other, none of the follicle will appear round or oval. If the follicles don't appear round or oval, you cannot take the mean diameter as the correct size assessment for the follicle. isn't it? Say for example, I am talking about this follicle here, okay? This follicle, which is same as this follicle. If I take a longest diameter, it is this diameter. If I take a longest diameter perpendicular to the longest diameter, it is this diameter. But the follicular size is much smaller in all other areas rather than that longest diameter. So I'm always going to overestimate the size. Therefore, when you have multiple follicles, that is when this is one place where I would request, if at all the patients or the people who are doing IVF here, I'm sure they may have friends who also have 3D machines. So just for those patients, not for all the patients, for just for those patients, please send the patient to the radiologist or to any of your friends who has a 3D 4D machine and take a volume of this and get a Sono ABC done. What is Sono ABC? It color codes every follicle, as you can see there. Not only it color codes the follicle, but therefore it identifies every follicle, and then it measures X, Y, Z diameter, mean diameter and volume of every single follicle. Now what is the advantage of all this? To know the correct size of the follicle. Why do I need to know the correct size of the follicle? Because I want to find out, one, the correct time of the trigger. Two, I want to find out what to give as a trigger, and how to prevent OHSS and how to prevent multiple pregnancies in IUI cycles. So if I say that, the first thing that I want to tell you is, though we usually take mean diameter as the diameter of a decision, we actually are doing wrong. As I told you, the mean diameter in irregular follicles is not going to give you the correct diameter. You have to take this diameter, which is called volume release diameter. What is a volume release diameter? You have the volume of the follicle, which is irregular, make a sphere of the same volume, and the diameter of that is the volume release diameter. That means now you know the correct size of the follicle. And if you see there is, even if you see just the first follicle, there is a difference of 3 millimeters in size. So that makes a huge difference in your decision making, and therefore whenever you have multiple follicles, that is when I would request you and suggest you, for all my friends who are doing IVF, please get a Sono ABC done so that you can make a correct decision of the size of the follicles and the correct decision of the trigger. Yes, it is true that when you are doing an IVF cycle, that is when you would always wait for at least 3 follicles between 16 and 18 millimeters before you give a trigger. But we all know who are doing IVF that n number of times it may happen that you have given a trigger, you do a pickup and there is nothing inside. Why is there nothing inside? Not that the follicles are truly empty, because the final meiosis has not been triggered, and it is because of that the oocytes don't separate. The cumulus doesn't separate out of it, and you don't get follicles. Why would that happen? Because the LH has not acted on it. Why is the LH not active? Because you have not checked the flows. You do not know what is the LH receptors. You do not know what the LH receptors have developed or not. Therefore, even if you are doing an IVF, check for flow in at least 3 follicles on both the sides. And if those have flows, you can give a trigger, and you will never have an empty follicle syndrome. And I can tell you that out of my experience, it's been since 1999 that I'm using Doppler. And since then, I have not had even one case, and I can swear on that, not even one case of empty follicle syndrome. So this is something very, very important to understand. Look at the flows for at least 3 follicles on both the sides before you give a trigger, even in your IVF cycles. Okay, so that is about loops. Loops? What do you mean loops?
Luteinous unrupture.
We will talk about it. We will talk about it. It will come later. In the course of time it will come. So, you must always check that there is flow, and after that you give a trigger and you will have excellent flows. So that was just about the size of the follicle. Now, I was going to tell you about what should you give as a trigger. This is important both for your IUI and your IVF cycles. We know that when we use gonadotrophins, one fear is OHSS, and the second fear is multiple pregnancies, especially when you are doing IUIs. This can be prevented as you know, by agonist trigger, which has become very popular now. Agonist trigger. We are talking just about IUI first, ma'am, so that's why I didn't say antagonist cycle. So we will talk about both one after the other. So if I am doing IUI, my fear is 1, multiple pregnancy, and 2, it is OHSS. What is the reason of OHSS? We say that HCG is the reason why OHSS occurs. And why is that so? Because when you give an HCG, there is a long surge which lasts about 48 to 52 hours, unlike the natural surge which is about 24 hours. So what? What happens is that the follicles which are functionally mature, which have good blood flows and adequate LH receptors, with the surge, they rupture and they form corpus luteum. Corpus lutea are not a cause of VEGF secretion, which is a culprit for OHSS development. The follicles which are suboptimally mature, which are say 15, 16, 17, 18 millimeters in size but have inadequate flow. Because they have inadequate flow, that means they don't perceive the LH fully, and therefore they go into LUF. They don't rupture, they go into LUF, and it is those follicles also. LUF is also not responsible for VEGF secretion. But the follicles which are between 11 and 14 millimeters, medium sized follicles, these follicles, they share FSH and LH receptors. Because they share FSH and LH receptors, when the LH surge comes, that is also felt as FSH, and the follicles keep on growing. Because HCG is a long surge, or the medium sized follicles which come in that range during that entire 48 hours, they all keep on growing. They keep on growing, but once the LH falls after the surge, they don't get luteinized. So they remain as growing. Of course, their growth rate decreases, but they still remain as growing follicles. And it is these follicles which secrete VEGF, and it is these follicles which are responsible for OHSS. That means that if you have more follicles between 11 and 14 millimeters, apart from whatever mature follicles, that is when you don't want to give HCG. Okay. Agonist has an advantage because it has a short surge. It has only 4 hours of rising limb. So only those follicles which are mature we will rupture, or only 1 or 2 follicles which are between 11 and 14, they will remain as growing follicles, and that would not lead to OHSS. So that means that if I am doing an IUI cycle, if I have more than 6 follicles of between 11 and 14, whatever the number of larger follicles, I will not give any HCG or that. If the number of follicles between 11 and 14 are between 3 and 6, I would give low dose HCG, which is called a dual trigger, where you give agonist full dose and you give only 1500 international units of HCG. Why do I want to put this 1500 of HCG? Because agonist only trigger has a very high chance of luteal phase defect. So to prevent that, I give that 1500. Moreover, in some studies, it has also been raised a doubt that with agonist alone, the final meiosis may not start, and that is also one reason why we would want to support it with a small dose of HCG. But if the number of follicles between 11 and 14 are less than 3, I don't mind giving even full dose HCG, not a problem, and that is a time-tested medicine as a surrogate surgery. But if I'm doing an IVF, I will give no HCG if the number of follicles between 11 and 14 are more than 8. I will give low dose HCG if the number of follicles between 11 and 14 are between 4 and 8. And I will give full dose HCG if the number of follicles between 11 and 14 are less than 4. In IVF, though you are going to aspirate every single follicle and make a rule to actually aspirate every follicle up to 10 millimeters in size, because there are studies which have shown that all the follicles up to 10 millimeter in size can give you fertilizable oocytes. you don't only get more number of fertilizable oocytes, but you would also prevent the risk of OHSS because you have aspirated them all. There are no growing follicles, they are all only corpus luteum. The second fear is multiple pregnancy in your IUI cycles. Now, if that is a fear, multiple pregnancy occur because multiple follicles may rupture. And if you give an HCG trigger, when there are multiple follicles between 17, 18, so about 17, 18, 19 millimeters in size with good flows, yes, that is when multiple follicles will rupture and multiple pregnancy can occur. But it is essential that you check the vascularity. If you have truly suboptimally follicles between about 3 to 4, apart from mature follicles, that's when don't give any HCG at all because you want only the mature follicles to rupture. Give only agonist. If you have just 1 or 2 follicles which are suboptimally mature and 1 mature follicle, that is when you can give a low dose HCG, not a problem. But if it is only mature follicles and no suboptimally mature follicles, you can give full dose HCG even if there are 2 or 3 after checking the flow because all of them will not be the same maturity and the same quality. So that is why you need to do a sono ABC and find out the size of the follicle, which tells you also about the type of trigger and the type of trigger. And you also know that there are studies which have shown that so same, it also depends on the medium sized follicles. There is a study, if I am not wrong, which has shown, just let me show you there. If there are more than 25 follicles of larger than 11 millimeters, that is when you would not give HCG at all. So this is the evidence which tells you that all the follicles up to 10 millimeters must be aspirated, and this is the study that tells you that all the follicles, if the number of follicles are larger than 11 millimeter or more than 25, you should not give HCG at all. Now coming to the endometrial assessment. The endometrium is nothing but, as we were talking with the live demos, it is nothing but a receptor organ to estrogen and progesterone. So if there is no estrogen, it is not going to grow. If there is no progesterone, it is not going to get luteinized or not turn into secretory bricks. So estrogen secretion starts with the dominance of the follicle because we know that with the granulosa cells, if you are all tired at any point of time or you need a small refreshment, just let me know. We will stop for 2 minutes and we can start again, okay?
Can take a cup of coffee?
No, I'm okay. I don't.
If you are okay, we are also.
Yeah, we are fine. So the follicle, as soon as it grows to dominance, that means it gets receptive to FSH, the granulosa cells, they start secreting estrogen. As early as about day 6 of the cycle, the endometrium starts getting multilayered. In the mid-proliferative phase, the normal endometrial growth rate is 1 to 2 millimeters a day. And it is in the late proliferative phase that it decreases and becomes 0.5 millimeters a day. Now, that growth of the follicles, that growth of the endometrium, as it grows, it is these two side lines, naturally they are going to separate. As they separate, there is a space created, so-called space, an evident space, it's not a space. That's where you see hypoechoic or anechoic areas in between the lines. It's a multi-layered endometrium with hypoechoic, severely hypoechoic or anechoic area between the lines, and that is what is called a grade B endometrium. That is usually found in presence of 1 or 2 mature follicles. That means when the estradiol levels are approximately between 100, 150 to 300, 400 picogram per ml. But when there are more follicles, 3, 4, 5, 6 follicles, when the estrogen level is higher, that is when gradually echogenicities start developing between the lines. But these echogenicities are not more than that of the normal myometrium, and the triple layer pattern is still maintained, and this is called a grade A endometrium. But when there are truly supraphysiological levels of estrogen, which means that the estradiol levels are more than about 1000 picogram per ml, which happens with multifollicular development, or may sometimes also happen with only bi or a trifollicular development with PCO patients. That is when you would see that the endometrium loses its multilayer pattern and it becomes isoechoic to the myometrium. As long as the endometrium is isoechoic to the myometrium, it is not a progesterone exposed myometrium, it is pure estrogen dominated endometrium, and that all the three endometria are good for implantation provided the vascularity is good. That means the morphology of the endometrium does not tell me anything about the receptivity of the endometrium. Why should I document it at all? Is because it indirectly tells me about the follicular size. Why do I need to know about indirectly know about the follicular, it tells me indirectly about the follicular maturity. Why do I indirectly need to evaluate the follicular maturity? I am going to see the blood flows of the follicle. But with the Doppler technology has a limitation, and that is it does not have penetration. Its penetration is very low. Therefore, if you have an ovary which is lying posterior to the uterus, or you have an ovary which is lying deep, even if there is a follicle, even if there is a flow, if you put on a Doppler, you will not see that flow. So it is in these cases that you can evaluate the endometrium. If
tips and the experiences of our work in the center, we are really enjoying, and Madam is also continuously giving us the information. So we need a much break, and this is a break and prayer time, and we have to shorten it because the time is, we are running behind the time. I think at least 2:15 we should reach here. 2:15, okay? So enjoy your lunch and have prayer and have a break and come with fresh mind. Thank you so much.
So you are talking about direct and indirect signs of adenomyosis. Is that what you are talking about?
Yeah.
Okay. So if you say direct signs, you are seeing here hyperechoic dots and lines. You seeing hyperechoic dots and lines?
Yeah.
That is first criteria, which is a direct criteria. You are seeing one tiny myometrial cyst here, which is the second criteria. You are not seeing any hyperechoic islands, but all criteria may not be present in all the patients. Then amongst the indirect criteria, you are seeing complete irregularity of the junctional zone here.
Yeah.
It is irregular here also. You are seeing hyperechoic flex in the junctional zone, which is because of collapsed myometrial cyst.
Yeah.
And you are also seeing a slight abnormal curvature of the endometrium with asymmetry of the myometrium. Okay? And then if you put on a Doppler, I don't want to put it here, but if you put on a Doppler, you would see that the vessels, they are arranged chaotically. That means that instead of vessels, normal spiral vessels which are parallel to each other and perpendicular to the endometrium, here you can see completely chaotic arrangement of the blood vessels, and moreover, if you look at the spiral vessels, the diameter of the pre-ovulatory scan, and we actually have started already discussing about the luteal scan, because we know that once the surge has reached its peak and the ovulation occurs, that is when the luteal phase starts. And we all know, as we have and this is a quick revision, that the follicle which is mature, that is going to rupture and will result into a corpus luteum. But the follicles which were suboptimally mature, which didn't have adequate flow, with the LH surge also, they will not ovulate and they will go into a luteinized unruptured follicle. How do you identify a luteinized unruptured follicle? The luteinized unruptured follicle can be diagnosed soon after the surge itself, when the outer margin of the follicle starts becoming hyperechoic and low-level echogenicities start developing inside the follicular cavity. remember that the major differentiation between the corpus luteum and the luteinized unruptured follicle is that when it is a corpus luteum, that is when, because of the ovulation, there is going to be hemorrhage in this cystic cavity, and that will show as either fishnet or honeycomb or fibrin strands, whereas the luteinized unruptured, as it says, unruptured follicle, it will not show any hemorrhage, but because of the thicker lutein cells, the fluid becomes very thick, and therefore you start seeing low-level echogenicities inside. So presence of the hemorrhage itself tells you it is a corpus luteum. We have already discussed about the changes on the luteal phase in the endometrium and in the uterine vessels, and it is important to understand that the luteal phase assessment can only be done in the mid-luteal phase. Before that, the progesterone levels have not reached a plateau, and unless it has reached a plateau, when it is still in a transit, you cannot document it as a low or a high level. So that is why the diagnosis of the luteal phase abnormalities must be done always only in the mid-luteal phase. And the mid-luteal phase is about 8 or 9 days post-ovulation. If we said that the pre-ovulatory RI tells us about the estrogen level, the perifollicular pre-ovulatory RI tells us about the estrogen level, it is the RI of the corpus luteum which tells us about the progesterone level. The RI of the corpus luteum can be correlated with the plasma progesterone levels, and RI of the corpus luteum can therefore be used as an adjunct to the plasma progesterone assay as an index of the luteal function. And the RI of the corpus luteum should always be less than 0.5. Though what I showed you today was artery falls below what was in the pre-trigger. So in the pre-trigger it was 3.2, here it is 2.5. So that tells me, yes, this is an adequate progesterone effect and there is an adequate progesterone receptor development. So if that is a normal luteal phase, what would be the abnormalities of the luteal phase and how would they be diagnosed? We know that the abnormalities of the luteal phase are luteal phase, luteinized unruptured follicle, and it is a luteal phase defect. If I say luteinized unruptured follicle, as we have discussed earlier also, this is a quick repetition, that it will develop as a result of surge on an inadequately mature or suboptimally mature follicle, or it may be because of inadequate alleged surge. Now, and we also know that it starts as hyperechogenicity of the outer wall of the endometrium, outer wall of the follicle, and that will, and it also be associated with low-level internal echogenicities. As we know, with luteinized unruptured follicle, there is luteinization, so there is initial conversion or a partial conversion of granular cells to thicker cells, and it is also going to result into some production of progesterone. So the endometrium, because of that initial effect of progesterone, is going to get compacted, the endometrial thickness will decrease. There will also be a mild hyperechogenicity, but if you put on a Doppler, because the progesterone level after that does not rise, therefore if you put on a Doppler, the vascularity will be scanty, and whatever vascularity is there will be a high resistance flow where the RI will be more than 0.6. So that is, and if you look at the uterine artery PI also, the uterine artery PI also will have, will be more than 3. So this is, uterine artery PI will be, yes, it will be also be more than 3. So these are the signs which tell me this is an LUF. If we know what is the cause of LUF, which we discussed, what will be the treatment? If I get LUF in this cycle, I must be sure that in the next cycle I do not give a trigger unless I have confirmed the blood flows, and I must assess my trigger agent if I have changed it for its quality, for its temperature control, and whether it has been taken correctly or not. So that means that a luteinized unruptured follicle once is not going to be a luteinized unruptured follicle in every cycle, and if you find a luteinized unruptured follicle in one cycle, you can definitely correct it in the next cycle, and you know exactly what you need to do for that. But that also makes us realize that Whenever there is a multifollicular development, that is when the follicles which are mature will rupture and convert into the corpus luteum. But we have to remember that the suboptimal follicles will convert into LUF, and remember that it is only one healthy corpus luteum which is required to support the luteal phase. So whenever there is multiple follicular development, presence of n numbers of luteinized and ruptured follicle in presence of one active corpus luteum is no problem at all. If it is only corpus luteum, it is only luteinized and ruptured follicles, that is a problem. But one active corpus luteum and the rest are LUF, that is not at all a problem. The second problem with the luteal phase is of course the luteal phase defect. And we know that the luteal phase defect can be because of two reasons. It may be because of inadequate production of progesterone, or it may be because of inadequate progesterone receptors in the endometrium. Whenever it is because of inadequate production of progesterone, there will be a corpus luteum. There is a cystic lesion which has hemorrhagic echogenicities, which does not have hyperechoic walls, and still if you put on a Doppler, it will show scanty flow. So that tells me that yes, it is a corpus luteum, but it has inadequate flow. That means that it is an inadequacy of the corpus luteum. So don't confuse it with LUF. I repeat, LUF will not have any hemorrhagic echogenicities. But here also the production of progesterone is less, and therefore the endometrium appears thin, non-hyperechoic, and it also shows, if at all vascularity is seen, it is a high resistance vascularity, and along with that the uterine artery PI is also more than 3. But if you find inadequacy of the corpus luteum, the treatment to that is HCG as a luteal support. Remember that if you want a good luteal phase, apart from progesterone, HCG as a luteal support is a time-tested medicine. It is very effective even in recurrent pregnancy losses to support the pregnancy. We give HCG to all our patients along with vaginal progesterone as a luteal support, day 5, day 9, 5000 IU. 5000 IU. So day 5, day 9, post IUI, 5000 IU. And it works very well. If you don't want to give 5000, you can give day 2000 international units, day 3, 7 and 10. So this is an additional luteal support that you will give in the next cycle, and it works. If at all, 3, 7, 10, 2000, 5 and 9, 5000. The second possibility is that there will be a luteal phase defect because of inadequate progesterone receptor development. So in this case, the corpus luteum is absolutely normal. But the endometrium, in spite of normal corpus luteum, in spite of normal corpus luteal flow, still the endometrium will be thin, non-hyperechoic, scanty flow, and the uterine artery PI will be high. If I say scanty flow and if I say high resistance flow, there is a table which shows us normal spiral artery RI in a normal case in the mid-luteal phase, and this is the gradient between the two in cases of LPD. That means you get a very high resistance flow because the progesterone is not being perceived by the endometrium. If this is the case, what is the reason? Whenever you see that there is inadequate progesterone receptor development, remember that the development of the progesterone receptors is fully dependent on the estrogen priming of the endometrium. So, if the estrogen priming of the endometrium is inadequate, only then there would be progesterone receptor defect. What do I mean by estrogen priming, and how much, and how do I evaluate whether the estrogen priming is adequate or not? If the duration of estrogen exposure to the endometrium, that means from the day of dominance till the day of trigger, if the follicular maturity takes 4 to 6 days, that is a sufficient estrogen exposure to the endometrium. And on the day of the trigger, if you have checked that the follicular flows are adequate, that means estrogen level is adequate. So the duration is adequate, the amount is adequate, that tells you the estrogen priming of the endometrium should be adequate. That means inadequate estrogen priming can be resulting from given a trigger before the follicle is mature, or the follicle rupturing on its own before it achieved the PSV, or it may be because of fast development of the follicle. That means the follicle, instead of growing at 2 millimeters a day, it's growing at 3 millimeters a day, or even faster. Sometimes it does happen. You've seen a follicle today which appeared like 12, 13, and day after you see and it's ruptured. So premature rupture or fast development of the follicle will lead to shorter duration of estrogen exposure, and that is also one of the important reasons for inadequate estrogen priming and therefore a progesterone receptor defect. That means if I find inadequate progesterone receptor development, the first thing I will check is how was my stimulation protocol and how was my proliferative phase. Did the follicle rupture after I had seen the flow? How many days did it take? Therefore, whenever you have a follicle on the baseline scan which is already 10-11 millimeters, that means already have achieved dominance, that means it's an early recruitment of the follicle. In these cases, because the follicle has already become FSH sensitive, if you start FSH then with your routine dose, that is when the follicle will mature very fast because the endogenous FSH is also high. Yes? Therefore, it is in these cases where you find early recruitment of the follicle. That is when you have to start with one dose lower than what we will understand by the baseline score. So that will delay the growth, that will slow down the growth of the follicle by 1 or 2 days, and therefore there will be adequate estrogen exposure, adequate duration of estrogen exposure, and then you can give a trigger when the follicle matures. So that is the treatment if you have inadequate progesterone receptor development. But there is one cause still there. Your proliferative phase may be absolutely normal, your ovulation induction is normal, but unfortunately, during the proliferative phase, the endometrial flow has not developed. If the endometrial flow has not developed or has developed very late, in those cases, adequate estrogen, though it is produced, it is not delivered to the endometrium. And therefore also it may result into progesterone receptor defect due to inadequate estrogen priming, and therefore in those cases you can add anything that can improve the endometrial vascularity like aspirin or sildenafil or nitrogen patches or so on. Remember, never ever add estrogen to a stimulated cycle. When you are adding estrogen to a stimulated cycle because you want to improve the endometrium, but the endometrium is bad because the endogenous estrogen is either not adequate or it is not bioactive. That means the fault is with the follicle. So ideally you have to treat the follicle, make it better. If you are on CC stimulation, move to letrozole with gonadotropin, or you are on the gonadotropin, you may have to change the dose, but very important thing is, when do you add LH? Of course, we will discuss this more with the baseline scan, but if you have a follicle which has grown beyond 14-15 millimeters but does not show flow and everything else looks normal, that is when you need to add 1 or 2 shots of LH, and that will improve the vascularity and that will improve the quality. This is only because of the polymorphism. So, very important to understand that why are we doing luteal scan. When the patient fails to conceive, that is when we are confused, we are frustrated, patient is frustrated. So what to do, we do not know. So every cycle the patient doesn't conceive, we keep on adding drugs to the luteal phase. Because everything till the day of surge we have seen. We keep on adding drugs to the luteal phase. And finally after 2 or 3 cycles, patient conceives without all those drugs. She might have conceived even without those drugs, but you feel that she is conceived because of those drugs. Unfortunately, all the following patients will get the entire list of drugs every time. And then even if that patient doesn't conceive, your frustration has no limit because you don't understand what went wrong. Therefore, the luteal phase assessment is essential. If the luteal phase is normal, that means everything that has been done and happened during the proliferative phase is all normal. Don't change anything. because the human reproductive endocrinology and the physiology is such that it needs to stabilize itself when you are giving exogenous medicines, and that may take 2 or 3 months. So if everything is okay, don't change anything. Luteal phase is normal, continue the same protocol for 2 or 3 cycles and the patient will conceive. But if you find any fault, you know what to do. If you find that the luteal phase is abnormal, you know what to do with the patient in the next cycle. So that is why the luteal phase scan is very, very important. Now moving to the baseline scan right away. This is the scan. So this is the scan that we do to find out what should be the gonadotropin dose to a patient. It is to assess the ovarian reserve and the response. Ovarian reserve and the response are the two terms which have been used for years together as interchangeable terms. But we have to understand that there are two separate things. Where reserve tells you about the number of follicles that will develop at the end of stimulation, it is the response which tells you how much push or how much dose of gonadotropin these patients will require to produce those number of follicles. That means that the number of follicles that the patient will grow, which depends on the number of antral follicles and the ovarian volume, it is the response, the daily dose of gonadotropin required will depend on the amount of flow in the ovary. Why? Because if the flow to the ovary is more, that is when more percentage of total gonadotropins more percentage of total gonadotropins present in the patient's blood, whether it is endogenous or it is exogenous, will flow into the patient's ovary every cardiac cycle. And therefore, as we said, FSH has to reach the antral follicles to make them sensitive to FSH. You remember we talked in the morning? And it is during this antral follicle phase that the follicles do not have vascularity. The FSH reaches those follicles by the way of diffusion from the stromal vessels. So there should be adequate amount of stromal flow so that sufficient amount of FSH can go into the antral follicles, which we call FSH threshold. Right? So to reach that FSH threshold, if the flow to the ovary is more, because more percentage of total gonadotropin in the patient's system flows into the ovary every cardiac cycle, the threshold will be reached easily. And therefore, the total amount of gonadotropins required for that patient will be less. Whereas, if the total flow to the ovary is less, that is when less percentage of total gonadotropins present in the patient's blood is going to flow into the ovary every cardiac cycle, and therefore to reach that threshold, you have to put much more into the patient's system. Therefore, the patient who has less flow in the ovary is a poor responder, and the patients who have more flow in the ovary is hyper responder. We all know that we have seen patients with multiple follicles but not responding. You have to give them higher doses. And we have seen patients with low reserve ovaries, 2, 3, 4 follicles, but you give just 2 or 3 shots of gonadotropins and they produce good follicles. So it is very important to understand both, that whenever you want to evaluate or whenever you want to calculate the dose for a patient, a dose of gonadotropin for a patient's ovulation induction, it is important to look not only at the
Not only at the number of antral follicles and the size of the ovary, it is essential to also look at the flows, and there is a literature evidence to that too. Measurement of the ovarian stromal flow in the early follicular phase is related to the subsequent ovarian response in the IVF treatment. These are 3D power Doppler parameters. If they are high, the patient is a good responder. If the levels are low, the patient is a poor responder. Even in patients with endometriosis, where you usually expect a poor response, if those patients, they still have a good stromal flow, they may still respond well despite what is the size of the follicle. And even if you are not using a 3D power Doppler and you are using only 2D also, the ovarian stromal PSV, even after pituitary suppression also, that means even in the cases who are down-regulated, it is predictive of ovarian responsiveness and outcome of the IVF treatment. From the literature evidences and our experiences, we have found that the patients who have an ovarian stromal RI of more than 0.7, the PSV of less than 5 centimeters per second, they are poor responders, whereas if the RI is between 0.6 and 0.7, the PSV is between 5 and 10 centimeters per second, these patients are normal responders. And if the RI is less than 0.6 and the PSV is more than 10 centimeters per second, which is usually found in the PCOS patients, these are the patients who are hyper responders. That means, and we have already discussed with the live scans as to how to measure the stromal flow, just a quick revision. You would switch on, you would locate the ovary, you would switch on the Doppler. Once you have switched on the Doppler, then you will scroll across the ovary to look at the vessels. When you find a vessel which is seen, vessel or vessels, which are seen in their long axis, vessels because it may be ovarian artery and it may be also ovarian branch of the uterine artery. Sometimes they are spiraling over each other, sometimes they are lying side by side. So find out where you find these vessels which are seen in their long axis and can be seen even outside the ovary, extending outside the ovary. Consider that as a hilar plane. From there, scroll your probe onto both the sides. And you are seeing vessels. You are not seeing hilar vessels now, and you are seeing those small vessels in the stroma. They should be away from the follicle also. And the brightest one, the flows can be measured in any of the brightest ones. That side, or even on the other side across the hilar plane again. So you can measure the flow in any of those. If you find multiple bright vessels, you can measure the flow in at least 3 vessels and find out the best combination of lowest RI and the highest PSV. That tells you this is your decision maker value. You have to do this for both the ovaries, and that tells you what would be the daily dose required for the patient. But it is not just that. As we discussed, it is also the reserve of the ovary. We know that we want to measure the reserve of the ovary, and I did tell you that we will count the antral follicles and we will measure the ovarian volume. The antral follicles we have already done when we were doing the baseline scan. You locate the ovary, scroll the probe so that you are not seeing the ovary, and then come back in the same direction, eyeball and count the number of follicles. Now, as long as the number of follicles are up to 12 to 15, that is when, whether you are using this method, which is scrolling across, or you are using a 3D method, both are equally reliable. But if the number of follicles are more than 15, that's when the human error, chances of human error increases, and then it is in those cases that we would suggest you to do a sonography. But sonography is required only if you want to do an IVF. If you want to do an IUI, sonography is not required. For the IUI cycles, we are not going to produce more than maximum 2 or 3 follicles, and therefore it is sufficient to decide the dose. It is sufficient to know that the follicle number is less than 5, 5 to 10, 10 to 15, 15 more, or 15 to 20 or more than 20. So their eyeballing is just perfect. But when you want to do an IVF, especially in the patients who are more than 15 follicles per ovary, that is when you may do a sonography, and this is required because if your stimulation protocol is optimal, the total number of follicles that you will develop with your stimulation protocol will be 60% of the total antral follicles. That means that if you have say for example 40 follicles, you will produce about 24, 25 out of it, but we know that ideally we should not produce too many follicles in any ovary, because that is not only injurious to our health, it may lead to risk of life, and moreover, what will you do with them? They are not required. So therefore, and moreover, the higher the number of follicles, of course, we are going to do a frozen transfer in them, so the progesterone is not going to affect. By chance, we have to do a fresh transfer. With the high progesterone, the estrogen-progesterone ratio in the luteal phase is also affected, which would affect the pregnancy rate. So ideally, the literature also mentions that 8 to 15 follicles, if you produce, it's a good result. So in those cases, you may have to decrease the dose. And therefore, it is essential to count the enteral follicles correctly. I know, the question would be, AMH? We don't do AMH? If you are going to do an IUI, no AMH is required, because what is the number of follicles you want to work with? If you do a scan and if you see 2, 3, 4 enterals, more than enough, you don't need anything else to do. But if you are going to do an IVF, again, then also, AMH practically is of no use at all. AMH is only important, one, when you want to document the patient as having almost zero ovarian reserve, and you want to tell her, you might require a donor, we cannot work with your follicles. Even when the number of follicles are sometimes 4 or 5, but the AMH level is very low, it is a possibility that there may be a poor quality follicles. It is in these cases that it is always better to opt for IUI rather than IVF, because doing IUI selects the best quality. It is a nature's selection of the best follicle, and therefore the chances of pregnancy are much, much better. Moreover, if you look at that, those evidences which all say that whether you do AFC or AMH, it is not going to make any difference practically. And even if you do AMH, are we going to ever start stimulation without doing a scan? No. So why not depend on our own abilities rather than depending on the lab technician's abilities? Isn't it? So, of course, and the expense is also important. So that is why, and let's look at the evidences. Number of retrieved oocytes correlates with enteral follicles and ovarian volume. Multivariate analysis has confirmed that AFC represents the most useful ovarian reserve marker to the controlled ovarian stimulation. In all the studied groups, as the number of mature follicles retrieved increased with the increasing AFC. AFC is considered to have best discriminating potential for the poor ovarian reserve patients compared to the total ovarian volume and all the other hormones. Whether you are using AFC plus AMH or you are using only AFC for poor reserve patients, both the models are equally efficient. A meta-analysis now which is considered the highest level of evidence. And for the poor ovarian reserve patients where we know this is the only group where we are much more concerned about AMH rather than anything else. Even there it is mentioned that AMH has at least the same level of accuracy and clinical value for the prediction of the poor reserve and non-pregnancy as AFC. That means, according to that meta-analysis, AFC is even better than AMH.
Yes.
Even in the hyper-reserve patients, high-reserve patients, AFC is also used to predict the hyper-reserve and thus using safe and successful stimulation regimes and to prevent OHSS. Both AFC and AMH are accurate predictors of excessive reserve to ovarian hyperstimulation. In one of our own studies where we compared AFC and AMH for the two groups, the normal controls and the PCO patients, for the two end results, the number of oocytes retrieved at the end of ovarian, number of oocytes retrieved on ovum theta and the follicles larger than 12 mm on the day of trigger. Because even the follicles larger than 12 mm on the day of trigger, they would all give you fertilizable oocytes. So these are the two end results which were selected, and we found that for both the groups, both the markers For both the end results did not show any statistically significant difference. That means whether you are using AMH or you are using AFC, the results, your accuracy, your prediction of the result is just the same. That for all practical purposes you can avoid the assessment of AMH. Even in the PCOS patients, it is mentioned in literature that AMH is of value in anovulatory patients, whereas AFC is effective in all phenotypes, whether it is oligo-ovulatory or it is anovulatory, and therefore it is a better tool to assess the ovarian reserve or even in the PCOS patients. Even in patients with endometriosis, the literature does mention that for the patients with endometriosis who are not operated, age and AFC. But those who are operated, only AFC is the marker for the ovarian reserve. And then both alone or in combination, they have the same predictive power. So why do both? You can avoid AMH therefore and just do an ovarian antral follicle count. And of course, if you want to, you can also add the ovarian volume, because we know that the smaller ovaries, they have lower reserve and they may result into poor response and cancellation of the cycle, whereas larger ovaries may be PCO and it is a risk of OHSS. So that is, and moreover, the studies have also documented that it is the follicle number between 2 and 6 millimeters which is significantly related to age and also independent of age to all the ovarian reserve tests, suggesting the number of small antral follicles represents the functional ovarian reserve. There are n number of evidences. If I keep on showing you, it will take us at least half an hour to go through them all. But we know that AFC and ovarian volume and the stromal flows are good predictors to decide the daily dose of gonadotropins, and since they do not even change after a short-term downregulation, therefore you can use them for your IUI cycles, you can use them for your IVF agonist cycles, and you can also use them for your IVF antagonist cycles. Apart from this, what would affect the daily dose required? Of course, we all know whatever the other parameters, the age is one single and very important factor which may affect the requirement of FSH for the patient, and the second is BMI. So we can take those also into consideration. That means now we have the 6 parameters which can help us decide the daily dose of gonadotropins. And we did several studies starting from about 2003 to 2011. In 2011, we came out with a few parameters of these values which would tell us higher or lower doses required. But still, to be more specific, after that we started a new study to make the stimulation protocols easy and easily calculable, and that is when, using the same 6 parameters, we developed a baseline scoring system. This was published in 2016, and when it was published then, it was based on 1570 IUI cycles and 350 IVF cycles, and it resulted into a 0 OHSS. In fact, let me tell you that we have, even when we were not using this baseline scoring system, as I told you, with our studies where we had just simple values which would tell us these are the patients who would require higher dose or lower dose, even then we never had OHSS. So I have practicing in an infertility center since 1999, 25 years now. I have not seen a single case of OHSS, in spite of the fact that all our cycles, even IUI cycles, are gonadotropin cycles. So this definitely is an excellent way of deciding the stimulation protocol, but this made the things even more easier. After that study, we continued the study further. It is a multicentric trial going on. We have finished more than 7,000 cases. 0 OHSS, 0 cancellation of the cycle, no conversion of IUI to IVF, no conversion of IVF to IUI. So it is a very foolproof and a very effective method, provided you have measured your stromal flows correctly. So if you just learn to do that,
You use FET or fresh?
anything. Depends on the case. If we have more than 3-4 blastocysts, we would do frozen. If we have less than that, we would do fresh. Whatever it is. So, but the results that I'm talking about is only about fresh cycles. We have not included the frozen cycles in this because we wanted to evaluate our stimulation protocols. So, what is to be done is this, and it is very, very simple. You only have to do a baseline scan. On the same day, you are going to document age and BMI. After that, you would write down, you would find out the enteral follicle count, volume, ovarian stromal RI and PSU. If you are going to do an IUI cycle, only the ovary which has better flows is to be taken into consideration for the decision. And if it is an IVF, you take a mean of it. Put the values into the table. Say for example, there is a patient who is 32 years of age, who has a BMI of say 29, has a AFC of 7, ovarian volume of 6 cc, stromal RI of say 0.6 and the stromal PSV of 4. That means her score comes to 3 and to 5 and to 7 and 3, 10 and 3, 13 and 2, 15. Yes? Now depending on what is the score, there is a prefixed dose, whether it is an IUI cycle, it is an IVF fresh transfer cycle, or it is an IVF frozen transfer cycle. This dose, at the most, you might have to increase the dose once, but otherwise in most of the cases, in more than 80% of cases, you don't have to change this dose, and this takes you to the mature follicle and the good endometrium. So how do you follow up the cycles? We know what is the baseline score, we know what is the dose depending on what is the treatment, and then we start stimulating the patient. Say for example, we first talk about the IUI cycle. Whatever protocol it is, I repeat, if it is oral ovulation cycle, you don't have to do a baseline scan. But if it is a gonadotrophin to be used, that is when you need to do a baseline scan. And baseline scan done once works for at least 6 months. That means only when you convert a cycle from IUI to IVF, you will have to repeat it. Otherwise, it is to be done only once during the treatment. You don't have to call the patient every time on day 2. So that is important. Now, if you are doing a gonadotrophin cycle, whether it is a letrozole plus gonadotrophin or only gonadotrophin cycle, the dose remains the same. The daily dose remains the same. Only the number of days of stimulation decreases, right? So what you do is, you are going to do a first scan. You are going to do a first scan. On the day you are going to start gonadotrophin. Yes? And on that day, as we have discussed earlier also, if all the follicles are smaller than 10 millimeter, you directly call them after 5 days. When I say less than 10 millimeters, we put the flow and we confirm that they are not dominant. Right? That means no dominant follicle directly after 5 days. But if there is already a dominant follicle, you know that they have FSH receptors and they are going to grow at a rate of 2 millimeters a day. So accordingly call the patient. If the FSH receptors have already been developed, that means there is no chance that it cannot respond. It is going to respond 100%. So in that case, no response is not an option. But here, when all the follicles were smaller, and you call them after 5 days, and if there is no response. When do you say it is no response? When do you say it is no response? When there is no follicular growth and there is no endometrial growth. Only then you call there is a no response, because even in the absence of follicular growth, if the endometrium is growing, the endometrium is growing only because estrogen is secreted, and estrogen is secreted because FSH is acting on the granulosa cells. So FSH is, if it is acting on the granulosa cells, in the next 2 or 3 days the follicle will also start growing. So if one of the two is growing, your drug is effective, don't change the dose. You understand my point? And therefore call them after 3 or 4 days depending on the follicular size. Yes? But if both are not responding, which means the patient is not responding, and the primary score was less than 10. Less than 10 means low AFC, low volume, high RI, low PSV, increased age and increased BMI. That means poor reserve, poor responding patient. In those cases, add 75 international units of RFSH on the same days. These all doses are RFSH. If you want to, I will show you the conversion for the urinary also. So you add 75 international of RFSH on the same day, 5th day of stimulation. But if, and again call her after 5 days because the follicles are still smaller than 10 millimeters. If the primary score was between 10 and 20, that means it is a normal reserve, normal responding patient. You are seeing on day 5 of stimulation, no response. So call her after another 2 days. Even then if there is no response, then increase the dose by 37.5 to 75. How do I decide? If the total antral follicle count is too high, more than 20, then add only 37.5. If the total antral follicle count is between 14 and 20, then add 50 international units. And if the total antral follicle count is less than 14, you can add 75. If the total score is more than 20 to 22, which means it is a PCO patient. That means you don't want to go for a hyperstimulation, so you stay on day 5, but you don't increase the dose. Call them after another 5 days with the same dose, and when they come after on the day 10 of stimulation, when I say stimulation, it is gonadotropin stimulation. So when you say them on the day 10 of stimulation or day 10 of gonadotropin, even then there is no response, that is when you would add only 37.5. But if the score is more than 22, severe PCO patient, typical chronic low dose protocol is what we are going to follow. See on day 5, no response, continue same dose. See on day 10, no response, continue same dose. See on day 14, and even then there is no response, only then add 37.5. And if your stromal flow is correctly calculated, you will not need to increase the dose for the second time for sure. Whereas if it is an IVF cycle, we cannot continue stimulation so long. We know we have a limit of 10 to 12 days of ovarian induction. So you are going to do there, you are always going to do a scan on day 2 and you start stimulation. And if on day 5 of stimulation, when you call the patient, if you see that there is no response, again, no follicular growth, no endometrial growth, that is when you will increase the dose depending on the baseline score on the same day. If the patient's score was less than 10, add 75 RLH to 75 and 75 RFSH, or add 150 HMG. If the score is between 10 and 20, normal reserve, normal responding, then you will add only 75 RFSH. And if the score is more than 20, PCO patient, add only 37.5. And then call the patient after 2 or 3 days according to the size of the follicle. So that would be your IVF stimulation protocol. Now, if I am talking of only RFSH, why did I here ask you to add LH? It is not a random decision, it is a scientific reason for that. If I am talking of patients who have low score, which means they have low flow and they have less size. If they have low flow, that means it is important to understand that the ovarian stromal flow is a function of VEGF and it is a function of LH. It is LH which leads to neoangiogenesis, so new blood vessel formation, and it is LH which is responsible for low resistance flow because of catecholaminergic stimulation and leukocyte cytokine activation. So if we just remember that it is LH which is responsible for the stromal flow, if I have a less score, that means the flow is also less, and therefore these patients are going to respond poorly. But not only that they are going to respond poorly, it indirectly indicates that the LH is either has a low bioactivity, or it has a receptor polymorphism and it is not perceived, or the LH level is low. So it's only in this group of patients that you need to do an LH supplementation. As far as IUI is concerned, as I told you in the morning, most of the times LH supplementation is not required, because no matter how poor reserve a patient is, she still has some amount of LH, and we are not going to downregulate them, and that LH is sufficient for the follicular maturity. But in IVF cycles, the patients who have low LH, we are going to downregulate them. That LH is further going to go down, will almost reach nil levels, and therefore in these patients you need to do a LH supplementation. The only one thing, and this is the same as also been described in the Poseidon criteria. If you see Poseidon criteria 1 and 2, the patients who have low reserve but still respond poorly, these are the patients who require LH stimulation. In the IUI cycles, I forgot to tell you what I was telling. I did tell you that in the patients who have follicles up to 14-15 millimeters they reach, but they still don't show flow, these are the patients who would require LH supplementation. There's only one thing that needs to be remembered, and that is, if you are on the day when you are going to start gonadotropins, and if all the follicles are smaller than 7 millimeters, follicles, they are androgen dependent up to 6 or 7 millimeters. Beyond that, they become FSH sensitive. Beyond that, 9 or 10 millimeters, they become FSH dependent. So as long as the follicles are all smaller than 7 millimeters, there are no FSH receptors. Even if you give FSH, it will increase the blood level, but it will not work on the follicles. On the other hand, it is androgen which not only recruits follicles from pre-antral to antral, but it also sensitizes the follicles to FSH. So if you start FSH that early, not only you will consume more FSH, but you will also lead to multifollicular development, because the blood level is increasing and more follicles are getting sensitized. So it will lead to multifollicular development. So if all the follicles are lesser than 7 millimeter, on the day of your start of gonadotropin, in your IUI cycles, you can delay the stimulation for a day or two, which will ultimately result in a mono or a bifollicular development. Yes? So that is for the baseline scan. Now what I know, your questions is, I am doing the baseline scan, and if I am seeing already a cystic lesion there is a cystic lesion which may be anechoic or which may have internal echos. What is the significance? If you have an anechoic cystic lesion which is less than 12-13 millimeters, which means it is mostly an early recruitment of the follicle, put on a Doppler. If it shows flows, because we know as soon as the dominance is achieved, the flow will be there. So if it shows flows, it is an early recruitment of the follicle. If it is an early recruitment of the follicle, and it is for an IUI cycle, you should ideally not cancel any cycle, because if it says early recruitment of the follicle, that growth of the follicle beyond 10 millimeters is not possible without rising FSH. And if that follicle is grown, that means the basal FSH is high. If the basal FSH is high, the patient is aging. Ideally, any cycle should not be cancelled. You can start stimulation for that patient. Start with gonadotropins if you want to right away, but start with one dose lower. Say for example, my baseline score says this patient requires 75, I will start with 50 or 37.5. So that the maturation instead of 4 days will take 6 days, that should be sufficient. Instead, if I am seeing this cystic lesion which is more than 25 millimeters, which is more than 25, now say more than 15 millimeters. If it is more than 25, I will think in terms of follicular cyst, and if it is still within the range of 15 to 25, I will think of residual active follicle of the previous cycle. Residual follicle of the previous cycle. Why would there be a residual follicle of the previous cycle? Because in the previous cycle, when the surge came, there were 2 or 3 follicles which were still in the growing phase, mid-size. So they remain as growing follicles even in the next cycle sometimes. They don't regress with the menstruation, they may remain there. Whatever is the cystic lesion, put on the blood flow. Put on the Doppler. If you see blood flows, only then it is hormonally active. So this regressing follicle will show scanty flow, and if it is there, it is high resistance. Even if it is a follicular cyst, it will show scanty flow and it is high resistance. But if it shows no flow at all, most of the times it is a simple cyst. Of course, you have to, if it is a septated lesion, you think of serous cyst, adenoma and so on, but generally, this is what you commonly find on your fertility scans or on your monitoring cycles. If you see that there is a cystic lesion with hyperechoic walls and internal, low-level internal echogenicities, it is a residual LUF of the previous cycle, put on a Doppler, scanty high resistance flow, hormonally not active, not to bother about. If you see that it appears like a corpus luteum or a hemorrhagic cyst, so that is when you put on the Doppler. If you see that, so there are fishnet pattern, honeycomb pattern, fibrous strands inside, put on the Doppler, and if you still see a nice ring of color with a low resistance flow, that tells you that this is a residual active corpus luteum of the previous cycle. Confirm that the endometrium is thickened and hyperechoic. Confirm with the patient that she is not throwing enough this cycle. That tells you this is a residual active corpus luteum. It is in this patients, if you have done a scan on day 2, repeat a scan on day 5. And on day 5 also, if it shows that changes, or on the day when you are going to start gonadotrophic, if it still shows the same, that's when you omit the cycle. But if the flow starts decreasing, that means the corpus luteum is regressing and you can go ahead with the stipulation. If this lesion is showing high resistance, that means it is a regressing corpus luteum. Again, the progesterone that it is producing is not going to be adequately bioactive, is not going to come in the way of stimulation. Forget about it and go ahead with the next cycle. And even if it is a hemorrhagic cyst. Now if I say hemorrhagic cyst, remember hemorrhagic cyst is a term only used for those lesions where the corpus luteum has stopped functioning, so has no flow, but still anatomically has not regressed. That means it's hormonally not active, it's not going to come in your stimulation, don't bother about it, go ahead with your stimulation. That means it is only one lesion which you have to remember, and residual active corpus luteum. It is only in this lesion that you cancel the cycle. Rest all the cycles you can go ahead. If I talked about the follicle which is early recruited, and if it is an IVF cycle, remember that if you have multiple follicles following in the cohort, you can ignore that follicle and wait for the rest of the follicles to grow and start down regulation early. But if you, with that early recruited follicle, you have very few follicles on both the sides, don't take that chance and follow that follicle to give a trigger. Yes, so that is about the baseline scan. If you are all tired, you can go out, walk for 2 minutes and come back. Sorry? Yes, that is fine, but I am seeing exhaustion in lot of faces. I am seeing exhaustion on lot of faces. So let them freshen up and come back. We will wait for maximum 5 minutes, okay? You want to do early pregnancy first?
No, endometrium.
Endometrium. Okay. So endometrial pathologies on ultrasound and hysteroscopy. Endometrial pathologies can be what? It can be inflammatory, it can be post-traumatic like Synecdoche, or it may be neoplastic like polyps, hyperplasia, malignancy, so on. What we will do today is, we will restrict ourselves to the endometrial lesions that we commonly see in the infertile patients. Since we have been discussing infertility since morning, we will mention a little bit about malignancy, but we will not do malignancy in detail. So endometritis, if you say, it may be acute or chronic, and it may be of an obstetric origin or it can be of a gynec origin. The incidence you all know, but we know that most of the times when there is endometritis as a result of obstetric origin, there is a possibility of either products of conception there left, or there may be some foreign bodies in there, or there may be infection because of improper labor practices. Because of gynec origin, it is because most of the times associated with PIDs, the pelvic infectious diseases. It may be because of neoplasms of the cervix, it may be sometimes because of IUCDs, or maybe because of radiation therapy, because of atrophy and so on. But then, whatever the cause, let us see the findings, because cause we can find out from the history, but the findings we have to see on ultrasound. If we say it is acute endometritis, remember acute inflammation anywhere in the body will lead to two things, one edema and two hyperemia. The same thing will happen with the endometrium also. The endometrium becomes thickened, but the thickened endometrium is normal and natural in the proliferative phase, in the pre-ovulatory phase and in the secretory phase. Therefore, the acute endometritis can only be diagnosed during the early proliferative phase, when generally you expect a thin endometrium. So you're expecting a thin endometrium, you are expecting an avascular endometrium, but in spite of that, you see that the endometrium is thickened. The endometrium is thickened in absence of either an early recruitment of the follicle or a residual corpus luteum, and you also see that the junctional zone is irregular. This is what tells you it is acute endometritis. But as we know, acute endometritis is often an association with the PID, and therefore, oh yes, if it is of an obstetric origin, it is possibility sometimes it is because of anaerobic infection, and that is when you may see air in the endometrial cavity. Thank you very much, and sorry for the trouble. So you may see sometimes air in the endometrium, and that appears as hyperechoic endometrium, hyperechogenic shadows in the endometrium. If I say that it is often associated with PID, how do we know? Do we have other signs of PID? Yes, you may have blood or pus in the endometrial cavity. You may have free fluid in the pouch of Douglas or surrounding the adnexa, which may show tissue strands. It may show tissue strands, which is because of pus. And then you may also have pain on probe pressure. The cause for the fluid in the endometrial cavity that we saw here must always be sorted out by asking the detailed history and doing the systemic examination of the patient, which would tell you what is the cause of infection. When you see free fluid in the pouch of Douglas or surrounding adnexa, in PID, along with the free fluid, you may also have, the patient may also have acute salpingitis, and as I described in the morning, if there is acute salpingitis, there is going to be a thickened tube, and you can beautifully see here how the thickened tube looks like, and it also shows pruning of the fimbria. The fimbria, which otherwise looks beautiful like fingers, they actually appear like shortened fingers. This is called pruning of the fimbria. And along with that, if you put on a Doppler, you will also see vascularity, which is low resistance and is running across the width of the adnexa. Sometimes it may have progressed beyond the acute salpingitis, and there would also be a hydrosalpinx, and because it is an acute inflammatory hydrosalpinx, therefore it will also have thick walls, as you can see in that clip. There would be also thick walls. You can see a clearly thick mucosa there, which appears like tiny solid projections. And moreover, it is these tubes which are still easily distensible, and because they are distensible, therefore one end of it may appear much more wider than the other end. Moreover, as I was showing you in the morning, which I was not able to and I didn't want to spend time, we are also seeing the waist sign of the hydrosalpinx, and those are the signs which tell me, yes, this is acute inflammation of the tube. So we have seen free fluid, we have seen acute endometritis, we have seen free fluid in the pelvis. I have talked to you about acute oophorytis also in the morning. Progressing beyond that may result into a TO mass, and that would be either in the form of hydrosalpinx with a waist sign or incomplete septum. You may also sometimes see a large mass where you cannot differentiate between the margins of the tube and the ovaries, but it appears like a complex mass. And these are all the signs of acute inflammation. If it is an obstetric origin, found by the history, you must always in detail see the uterus, which is still involuting. Therefore, the myometrium appears bulky and absolutely heterogeneous, and you should see for any presence of foreign bodies inside the uterus, as well as you must also look for formation of sinuses. You can see here, apart from the heterogeneous endometrium, you also see a gap communicating outside. You are seeing it in here also. So find out presence of sinuses or foreign bodies in the endometrium. Those are all the signs of acute endometritis with or without PID. Coming to chronic endometritis, thin endometrium with altered junctional zone, which may be irregular most of the times. There may be hyperechoic flex in the endometrium. There may be hyperechoic flex in the endomyojunction. Sometimes you may also see hyperechoic flex in the myometrium. If you put on a Doppler, there will be scanty vascularity not only in the endometrium but also in the subendometrium. And apart from that, there may also be sometimes calcified flex. Whenever you see calcified flex, it is important to identify how thick they are. That is where 3D can be useful, but 3D is not always required. You can just put some saline inside, and if you put saline inside, you can beautifully see where exactly the calcification exists. If we are seeing chronic endometritis, we must always keep into consideration the possibility of tuberculosis, and if there are a few signs which are more commonly seen in tuberculosis, but they are not specific for tuberculosis. So if you find them and there are other supportive signs, you can say, yes, this is possibility of tuberculosis, but with tuberculosis you usually have to confirm it on a histopath of the local hysteroscopically found lesion. The signs that are more commonly seen with tuberculosis are: 1, thin endometrium, irregular junctional zone. You may find fluid in the endometrial cavity with micropolyposis, as you can see. If you have micropolyposis but you still do not have fluid in the endometrial cavity, the entire central line will look irregular. As I told you earlier also, you may have hyperechoic flex in the junctional zone. Hyperechoic flex may be present in the myometrium and in the endometrium also. And as we were seeing in the morning, see there is a fluid in the endometrial cavity with hyperechogenicity of the inner line, as we saw in the septic uterus. There may be contracted cavity and there may be scarring in the cavity, which all may be possibly due to tuberculosis. Apart from that, patients with tuberculosis may also show myometriosis, which are very common to what you see in adenomyosis. But in adenomyosis, if you put on a Doppler, they will show peripheral flow. When I say myometrosis, it is an anechoic lesion with peripheral hyperechoic margin. So if it is adenomyotic myometrosis, you will have peripheral vascularity, but if it is tuberculosis, you will not have any peripheral vascularity. And this is a very important differentiating sign, because both adenomyosis as well as tuberculosis will show you thin endometrium, will show you irregular junctional zone, will show you myometrial cyst. But it is only the vascularity around the myometrial cyst which will tell you it is adenomyosis, and no vascularity surrounding myometrial cyst which will tell you it is tuberculosis. Gynae, if we talk about, Gynae are best diagnosed on, even if you are doing only 2D, they are best diagnosed on the saline infusion sonohysterography, where you just need to put a Foley's catheter, which is 6 or 8 French. You can attach it with a connector so that a syringe can be attached with it. And you just put the balloon of the Foley's is fixed in the cervical canal, not above the internal os. And then you would have to distend the endometrial cavity only with about 3 to 4 ml of normal saline. And depending on the tightness of the gynae, you may see some fluid. You are seeing fluid here also. See, you are seeing, in this case, you are seeing fluid only in the lower half of the endometrial cavity. You are not seeing any fluid in the upper half, which tells you there is a complete gynae here. Here it is a gynae in the lower half of the body. Whenever, in fact, I will tell you, if you are seeing, this is another case here, where as in the morning I was telling you, if there are fluid loculi, this is a surest sign there are gynae. If you remember, somebody was there in the demo when we were doing. So these are all the signs which will tell you there are gynae. This is not nick, this is in the fundus. Oh, that is there. That it is just a small cavity, it's not a niche. It's not a niche. It is just like morning. It is just a small fluid collection. It is not a niche. I told you, when it is a niche, it has to be triangular. It has to have the base on the endometrium, and it has to have the apex towards the serosa. This is round. This is not a niche. And it is the base is also not on the endometrium. So this is more of just a bigness. And so first one is the upper one. I will stop here and show you, because since you have a question. In fact, let me see it very more closely. Probably both of these are Nabateans. Both of these are Nabateans, and they are not niche or anything. So, moreover, you may also, so it is sonohysto. Again, one more case here. See? You're putting in saline and you see your catheter is being withdrawn, and you can see the entire cavity is open. But even if you see here, the gynae are in the lower half. Look at that here, right? So this is a very effective way. There are again gynae seen here on sonohysto, seen here on hysteroscopy. So gynae is very, very beautifully, not only gynae, even polyps, they are very beautifully seen on the sonohysto. And therefore, you only need to do hysteroscopy for the treatment purpose. The diagnosis can be done only based on ultrasound. Apart from the signs of tuberculosis that I showed here, because the last sign was gynae, I have continued and finished with discussion on gynae, but tuberculosis, when it spreads beyond the endometrium and the uterus, you may also see free fluid collection, which is associated with septations, and the septations may have hyperechoic nodules. There may be a lattice-like pattern with low-level leukogenicities. There may be low-level leukogenicities in the fluid with floating cysts. Whenever you see floating cysts like that, that is when you should always rotate the probe and find out its relation with the fimbria, if there are any. If there is a relationship, if they are in the close vicinity with the fimbria, these are not floating cysts, these are fimbrial cysts. But if you don't find any fimbria around, these are floating cysts, and they may be an indication of tuberculosis. So that is what is all about endometritis, going to polyps, solid vision arising from the endometrium, intact endometrium-malmetrial junction, The prevalence is very high. You cannot exactly predict the prevalence, because just for the reason that most of them are asymptomatic, and the polyps may be single or multiple. Even if they are multiple, every single polyp shows a single feeding vessel, and it is a single feeding vessel which is diagnostic of polyp. As I told you in the morning, when there are small and subtle polyps, there will be only irregularity of the central line, and when you see that irregularity of the central line and you see it closely, that is when you identify, yes, there is a subtle polyp there and a subtle polyp there. So looking and observing the central line and its curvature is very important. Sometimes the polyps may be larger and they may fill up the entire endometrial cavity. You are seeing here also, it doesn't actually fill up the entire endometrial cavity but fills up the fundus. Whenever you have doubt, always put on fluid in the endometrial cavity and you can beautifully see the polyps clearly separate from the rest of the endometrium, and that is diagnostic. If you compare the ultrasound images with the hysteroscopy, they are absolutely correlating, and that is what is the beauty of ultrasound. I would tell you that since maybe more than about 10-12 years, we have stopped doing any diagnostic hysteroscopies. All the diagnosis can be done only on ultrasound. Hysteroscopy is only done for the therapeutic purpose. Generally, we know that the polyps have a single feeder vessel and they generally appear homogeneously ecogenic. But whenever you see that the polyp appears mildly heterogeneous in ecogenicity, as you are seeing here, or you would also see that the vessels inside this branch, that means that it is either adenomyomatous polyp or it is an atypia. When the resistance in these vessels is less than 0.45, that is when atypia is suspected, but the resistance is in the range of 0.5 to 0.6, that is when adenomyomatous polyp is suspected. Apart from that, whenever there is polyp, you may also have to differentiate it from the type O fibroid, we know, which is intraendometrial fibroids. And the important differentiating signs, of course, are single feeder vessel and the ring of vascularity. So single feeder vessel in polyp and a ring of vascularity in the fibroid. But a very important 2D sign is that polyp, since it is ecogenic, it is better seen on the proliferative phase where it is a multilayered endometrium, whereas fibroid, which is usually hypoechoic to the myometrium, it is almost the same ecogenicity as the ecogenicity between the lines in the endometrium, therefore may be missed in the proliferative phase, but because they are hypoechoic, they are best seen in the secretory phase. And the third important differentiation is that when there is a polyp, the endomyo junction is absolutely intact, whereas when it is an intraendometrial fibroid, that is when the entire junctional zone will be infolded. So those are the differentiating points between the fibroid, between the type O fibroid and a polyp. The endometrial fibroids, even if it is not type O, it's type 1 or type 2, that is when it needs to be evaluated as to how much of the endometrium is involved in it, and it is for that 3D ultrasound is of a great help. The 3D ultrasound can actually show you exactly as to how much of the endometrium is involved, and again look at the harmony, look at the synchrony between the laparoscopic findings and the ultrasound findings. Here there is a fibroid which is say type 1. This is a fibroid here which is again probably type 1. This is a muscular fibroid. This is again type O fibroid. So you will always see this same images on the hysteroscopy and the 3D ultrasound with the sonohystro or even without sonohystro. So that is something very, very useful whenever you have fibroids. Let us now move to another lesion. As I told you, if there is a large polyp, it may cause thickening of the entire endometrium, or sometimes it also happens that the polyp is not very large but there are multiple polyps. Because of that, they fill up the entire endometrial cavity, and therefore they may appear similar to the hyperplasia. It looks like a completely thickened endometrium. You may put on a Doppler, and it may show, if it is a single polyp, it may show a single feeder vessel, but sometimes if there are multiple polyps which are leading to thickened endometrium, it will appear very similar to hyperplasia, because the hyperplasia also shows regular distribution of the blood vessels, as you can see here. In these cases, again, sonohystero can be useful, but if you have confirmed that it is a hyperplasia also can be two types. We know that the hyperplastic endometrial tissue consists of stroma and the glandular tissue. If the glandular tissue is predominant, that is when you will see multiple anechoic areas of various sizes, and the vascularity is scanty. Whereas if you are seeing a stromal predominance, that is when the endometrium appears more solid, the tiny anechoic areas are there, but they are scanty and they are very small and similar in size, and moreover, it will show increased vascularity. It is often difficult to differentiate hyperplasia and the malignancy, endometrial malignancy in situ, because as long as it is in situ, it will show intact junctional zone, which is a characteristic feature of hyperplasia also. Whereas if it is malignancy, that is when the vessels will, the first thing is the junctional zone will be irregular, the endometrial thickness is more, the endometrial echogenicity is heterogeneous. If you put on a Doppler, it will show heterogeneous distribution of the blood vessels. The single blood vessel will all have various diameters, so the same vessel will be thickened somewhere, will be narrower somewhere. The vascularity extends into the myometrium, and these are all the signs which would tell you it is probably endometrial malignancy. Coming to fibroid polyps is a term very loosely used for any large polyp, but remember, when we say fibroid polyp, it has to have a myometrial component. So it actually arises from the myometrium and it protrudes inside the endometrium. It has vascularity, which is a single feeder-like vascularity with branching inside, but that origin of that vessel is not only from the spiral vessels, it is from deep from the myometrium, and that is the true fibroid polyp. There may be scars, there may be weakened scars, and anything like this. So if you can now differentiate what you saw earlier, so that is what is a niche. It is triangular based on the endometrium, and it is the apex is towards the serosa. We know that when the scars are large, you measure the distance from the tip of this triangle to the, from the tip of this triangle to the serosa. If the distance is less than 3 millimeters according to some studies, less than 5 millimeters according to others, it is considered to be a weak scar which will not hold the pregnancy or will not allow an abnormal labor. It is in these cases that a repair may be suggested, but not all patients will agree with it. But sometimes the scar niches are extending right up to the serosa. Sometimes we have also seen that these niches may be communicating with the peritoneal cavity, that will lead to continuous fluid leaking inside the endometrial cavity. In these patients, when you are doing monitoring, you will often see fluid in the endometrial cavity and will not allow the endometrium to grow well. It is all these cases where you would require to repair the niche, and after that the pregnancy is quite easy. Sometimes you may find absolutely atypical scars in the endometrium, and this is quite common when the endometrial, subendometrial fibroids have been removed, which is not very common in polyps. Subendometrial fibroids are removed, and these scars are very difficult to treat and very difficult to give a pregnancy in these patients. IUCDs, if we talk about, yes, generally we used to once upon a time measure the distances. If we're using only 2D, we used to measure the distance from the tip of this to the serosa, and we used to measure the thickness of the myometrium, and we used to calculate as to whether the IUCD appears in place or it is displaced. But now with 3Ds you can see the IUCD so very clearly that whether it is normal in position or it is displaced can be beautifully diagnosed only on 3D ultrasound. You can also find out whether it is invading into the myometrium, whether it is fixed there, whatever. So that is one more thing. So ultrasound is a modality of choice. Periovulatory is the phase where you assess it for all the endometrial lesions. Examination in the different phases of the cycle is still important. B mode and Doppler both are required. Saline infusion is very useful. Junctional zone assessment cannot be missed. So that is about the endometrial lesions. You want to do early pregnancy, you want to do only ectopics. You don't want to do early pregnancy, right? You want to do early pregnancy. Both. Is what? In certain parts of India it is high, but in our part of India it is not that high. So in our center we don't see tuberculosis very often, but yes, there are some places in south and especially in the central India where incidence is very high. And that is why I discussed tuberculosis in detail. Yes, it is very poor success with tuberculosis. Even if you do a stem cell transfer for Escherman, it works very well, but for tuberculosis it does not. It is only if it is diagnosed early and treated with AKT, it may help. Early pregnancy, yes or no? Yes? Okay. So if we talk of early pregnancy, let us not discuss about normal early pregnancy. I will go very fast through it. Let us only discuss about abnormal early pregnancy more in detail. We know that when we are talking about early pregnancy, we are talking about a pregnancy of 4 weeks till about 11 weeks, 10 to 11 weeks. And yes, it is right that you are not doing 3D, but this is not to fascinate you. It is truly to explain you that how much can a 3D do. How much can a 3D do? It can show you the details of the anatomy so very beautifully that you can never ever make a mistake in diagnosis. We know that pregnancy starts with the implantation of embryo, which occurs about 4 to 7 days after the ovulation, and the earliest pregnancy prediction can be done as early as in the mid-luteal phase. In the mid-luteal phase, when I told you that the corpus luteal RI has to be less than 0.5, this is a very important prerequisite for the pregnancy, because unless the corpus luteum is supportive, the pregnancy is not going to survive. Apart from that, yes, you all remember that in the luteal phase we saw the endometrium, and the endometrial flow should be present, and that should also be a low resistance flow. But we also need to remember that when we measure the flow here, if we look at the PSV also, and the PSV is more than 5 centimeters per second, this is one of the positive predictors of pregnancy in the mid-luteal phase. Not only that, in the mid-luteal phase or in the late luteal phase, if you see that the endometrial cavity, the endometrium shows asymmetrical thickening of the lips, where the thickened lip also appears hyperechoic. And if you put on a Doppler, if you see that the vessels are converging towards one single point, these are the signs which tell you that this is probably an early intrauterine pregnancy. This sign is called color comet sign of early pregnancy. But we know that this only predicts pregnancy. The confirmation of the pregnancy is done only after the missed periods, with either a positive urine pregnancy test or a positive beta HCG in the blood. And positive beta HCG is concerned as a specific sign for pregnancy, but we know that though it is a sign of a positive pregnancy, it may be seen even in the ectopic pregnancies. It may be seen positive in vesicular moles. It may be positive in patients with dysgerminoma, choriocarcinoma, extrauterine pregnancy and molar pregnancy also. That means whenever you see that the beta HCG levels are above 1500 milli-international units per ml, and still you are not seeing an intrauterine gestational sac on your transvaginal scan, that is when all these things must be always considered. If at all, those are the things which you consider if you don't see a sac. If you see a sac, intrauterine sac, if you have confirmed on the ultrasound, you need to check the viability and the prognosis of the pregnancy. You need to check the embryo for the structural abnormalities and the chromosomal abnormalities. The assessment for the chromosomal abnormalities goes back towards the pregnancy of about 12 weeks and nuchal scan, etc., which is what we are not going to discuss today, since we are discussing only the early pregnancy. But apart from the viability and the structural abnormalities, it is ultrasound which also helps you to find out if there are any intrauterine hematomas, if there are any abnormal locations of the pregnancy inside or outside the uterus, and also if there are any trophoblastic tumors. Starting with the viability of the pregnancy, normal growth rate of the gestational sac, appearance of the yolk sac, appearance of the growth, appearance and growth of the fetal pole, appearance of the cardiac activity. These all things have normal timelines and the growth rates, and they have to follow that to tell you that the pregnancy prognosis is good. Going very, very quickly, 4 weeks you will see a gestational sac 2 to 3 millimeters with anechoic central part and hyperechoic outer margin. It is always seen eccentric in the cavity, not in the center. It aborts the endometrial cavity only after, completely aborts only after 8 weeks. Till then you will see some endometrial cavity still, as you are seeing here also. And if you switch on the Doppler, you will see a lot of peri-sac blood flow, which is a positive sign for a live pregnancy most of the times, but not always. 5 weeks, you will start seeing the yolk sac inside, and you are also seeing a tiny fetal pole at the end of the 5 weeks, 5.5, 5.6 weeks. And it is, even when it is just 1 or 2 millimeters in size, it is only by the cardiac activity that we see inside to diagnose this is a fetal pole. This keeps on enlarging, becomes elongated in the 6th week. In the 6th week, you can also clearly identify the cephalic pole and the caudal pole. Beyond getting straightened, it then gets curved, as you can see here, and you are also seeing the neural tube development there. Tiny limb buds may sometimes be seen as early as end of the 6th week, but mostly it appears at the 7 weeks. At 7 weeks, you will also see the rhombencephalon. We are not going to put on the Doppler, so I am not going to talk of it. And you will, at the end of the 7 weeks, you will definitely see tiny limb buds, which are called hand and foot plates. The amniotic membrane must always be seen by 7 weeks, and by 8 weeks, you should be always able to see the limb buds clearly. It is by 8 weeks that the fetus straightens up a little, and it remains a bit straightened till about the end of the 11 weeks, and therefore when we date the pregnancy, we always plan to date it by 8 weeks, between 8 weeks and 11 weeks, and that is probably the most reliable time to date the pregnancy. Moreover, it is by 8 weeks that if there are any twins and they are going to vanish on their own, that will happen by 8 weeks. So 8 weeks is a scan which is truly an important scan. And if you find everything is normal at 8 weeks, most of the times the pregnancy prognosis is good. You would, by the end of 8 weeks, you will definitely see, apart from rhombencephalon, the rest of the other 2 cerebral vesicles. Also, you can beautifully see it on the 3D here. You are seeing a typical C there, which is a prosen, meson, and the rhombencephalon. If you look at it closely, you will also see the neural tube here. You would see that the limb buds have now developed into 2 segments, the upper and the lower segment. and it is the cephalic fold, which may also, if you see on the coronal section, will show the fourth ventricle too. At 8 weeks, umbilical hernia actually becomes visible only at the end of 8 weeks or 9 weeks, or starting of the 9 weeks. The limb births now are very clearly seen, and the hands also start developing. The cord insertion is seen, and the entire embryonic circulation is there. 9 weeks, the head makes half of the fetus. The facial details are faintly identified. The fingers, you can see here, the toes are seen. The fingers are formed at the end of the 9 week. The upper limbs though grow faster than the lower limbs, and the hernia is always seen at that stage. Not only that, you will see a clear prominence of the coccyx, thus identifying the neck and the coccyx separately. 10 weeks, you will see all the 3 cerebral vesicles. You will also see the cerebellum. You will see the hand and the feet. You will see the parts. The spine ossification starts. So that is all, those all things you can see. You can also see the choroid plexuses. You can also see the choroid plexuses. You will see the stomach, bladder. You will also see the kidneys, and you will also see the renal and the iliac arteries, and the heart has already become 4 chamber.
That's all done by TBS, right?
Sorry?
Transvaginal sonography.
Yes, yes.
Madam, could you please tell us
Always.
about anti-scan?
No, I'm not. Who asked me? Somebody asked me? If you want me to, I can include. In that case, we will have to cancel something else, because it's going to be actually too exactly, because it is more of a fetal medicine, and today we are discussing more about the infertility and the gynae scans. So you would also see the umbilical hernia that starts disappearing there, and you would also see the fingers and the toes. If you ask me, it is all transvaginal scan. Yes, let me tell you that with all the new standards nowadays, the entire first trimester assessment has to be done by the transvaginal scan. Not only that, even with the nuchal scan, we do a detailed anatomical scan, and that also we do it with the transvaginal scan. So transvaginal is a very safe way and a very effective way of evaluating the fetus, and you can, at 12 weeks, it is a completely formed fetus. You can see all the anatomical details very beautifully, including the nasal bone and everything, the stomach there. You can also see the details of the spine, the details of the ribs, and fingers and everything. And not only that, you can also identify the movements of the probes, the movements of the fetus, which are very active, and they are very, very decision, I would say gold movements, in the sense they decide, I am going to touch the nose, I am going to touch the eye, and I am going to touch the chin, and so on. So they are very definite and gold movements that happen. With that normal growth, what are the abnormalities that you can diagnose in the early pregnancy? It can be abnormal prognosis of the pregnancy, it can be abnormal location of the pregnancy, it can be pregnancies with vesicular moles or chorioangiomas, it can be pregnancies with uterine abnormalities, and it can be pregnancies associated with other pelvic abnormalities. Pregnancies associated with other pelvic abnormalities, which may be uteric stones, which may be appendicitis, which may be many other things, and therefore I have not included them here today in this presentation. The rest of the things we will discuss. Coming to pregnancies with abnormal prognosis, it can be abnormal gestational sac, it can be abnormal yolk sac, it can be small CRL, so the short CRL, it will be late appearances of the cardiac activity, abnormal cardiac rate or rhythm, abnormal amniotic sac bands, or it may be perisac hemorrhage. But before that, before you diagnose abnormal prognosis, or whenever you doubt an abnormal prognosis, that is when looking at the biochemical profile is very important. We know that during the pregnancy, the LCG rises during the first 12 weeks, then it may fall a little, and then it may reach a plateau and may continue or decrease beyond that. We know that the progesterone levels, they keep on rising, the estradiol levels also they keep on rising. If at all you see that this does not follow a normal pattern. When there is a fall in HCG or fall in progesterone or estrogen, before 10 weeks, these are the signs which indicate a bad prognosis, and therefore it is very essential that if we say progesterone is, I would say progesterone is the first sign, fall in progesterone is the first sign which would tell you that the pregnancy is not going to survive or it's a danger. We know that the progesterone levels can be predicted from the corpus luteal flows, and therefore it is essential that at least till 8 or 9 weeks, every corpus luteal flow must be evaluated. Every pregnancy corpus luteal flow must be evaluated. And if you find a rising RI in the corpus luteum, this is a sign of a bad prognosis. These are the patients, if they are supported by progesterone, even if it is a natural pregnancy, if they are supported by progesterone, can have a better prognosis. Looking at the other prognostication signs, let us start with the gestational sac. We know that the gestational sac is going to appear at about 4 weeks and 3 to 5 days, when it will be very small. It has a definite normal growth rate of about 1 millimeter a day, at least 1 millimeter a day. Regular thick echogenic wall, which you know, which is because of the double decidual reaction. It must be ideally implanted into the upper half of the endometrial cavity and should be eccentric in location. And remember that even at the beginning of the pregnancy, the decidual thickness should be at least 3 millimeters. When you measure the gestational sac before the appearance of the fetal pole, it is essential that you would always measure it as, or document it as, mean of 3 longest diameters. But once the fetal pole appears, this doesn't have much significance unless it is too large or too small, and therefore you can mention it as a single diameter. It is whenever the gestational sac is irregular, we know that it has a poor prognosis, and the reasons can be either it can be either myoma, uterine contractions, perisac bleed, over-distended bladder, etc. Or whenever you find that it is irregular, it is important that you would document the volume of the gestational sac rather than just the diameters. Ideally, it occupies about 1/3 of the uterine cavity at 7 weeks. Looking at abnormal gestational sac and gestational sac which has a residual thickness of less than 3 millimeter, it is too large or too small. Again, there is no size cutoff for the same, but it is too small and it is almost opposing on the yolk sac and the fetal pole, or it is too large where you have to find the gestational, the yolk sac and the fetal pole in some small corner. These are considered abnormal. When the sac is more than 9 or 10 millimeters and it doesn't show yolk sac normally will be seen when the gestational sac reaches about 5 millimeters. But if you don't see any gestational sac, when you don't see any yolk sac, when the gestational sac reaches 9 or 10 millimeters, that is an important sign to tell you there is probably something abnormal. But you don't document it as a failed pregnancy. You just alert yourself and the patient, I feel that the growth is a little slow and we will have to watch it a little more closely. Similarly, the fetal pole normally appears at 15 millimeters, but sometimes it may happen, it may not appear till then. And if that is the case, that is also a sign which would indicate a guarded prognosis. Abnormal gestational sac size is associated with trisomy and triploidy, and the growth rate of the sac, if we say normal is 1 millimeter a day, even if it doesn't grow, if it grows up to 0.7 millimeter a day, it's still fine. But if the growth rate is even lesser than that, that is when it is truly a bad prognosis. Though it is important to remember that the perisac flows always are not different in the normal and abnormal pregnancy, and therefore that should not be taken as the only parameter to tell you that it is a good or a bad prognosis of pregnancy. Again, quickly, the large gestational sac, the small gestational sac, and that is the perisac hematoma. You have to, when you see the perisac hematoma, every time you don't have to get disturbed. Many times it is only the unabated endometrial cavity, and the unabated endometrial cavity may also appear like a perisac hematoma. But when there is an unabated cavity, that is when, remember, you will see its continuity with the rest of the endometrial cavity. You may also trace it towards the cervical canal. With hematoma, again, there may or may not be bleeding. If it is bleeding, we call it a threatened abortion. If it is no bleeding, it is just an incidental finding. There may be a perisec hematoma. Perisec hematoma, it is not the size, it is location which is more important. Yes.
If there is a perisec hematoma no bleeding, then what will be the diagnosis of that?
Please a little loud.
When there is a perisec hematoma but there is no bleeding,
Yes.
what will be the diagnosis of mine in that?
The diagnosis is perisec bleed, but it is not a threatened abortion.
Another thing is gestation sac diameter is more than 16 millimeter, but there is no fetal core. What is the abnormality that leads into?
No, we have to wait and watch. It may not grow at all, or it may be resulting into any of the chromosomal abnormalities. But we have to wait and watch, only then we can say what happens to it. But it only says prognosis is poor. So perisec bleed, when you see it is towards the fundus, or it is larger than covering more than 1/3 of the gestational sac, that is when it is usually considered to have a poor prognosis. And moreover, when it is under the chorion frondosum rather than under the chorion leaf, so that is when it is more risky, that is when it has a bad prognosis. But the hematomas, which are smaller than covering 1/3 of the gestational sac, more towards the cervix rather than towards the fundus, and they also have, they are also under the chorion leaf. That's when they are not of much harm to the pregnancy. But I said not of much harm, I didn't say no harm. So it is very important that you would always counsel the patient with a proper safeguard. Even when you find uterine fibroids, or when you find uterine adenomyosis, even these lesions also, when they are under the chorion frondosum, they are risky. When they are on the chorion leaf side, they do not have much significance, especially as we are seeing today also in the morning, when the adenomyosis is too large. Having a pregnancy is not a problem if the endometrium is growing, but it is the second trimester abortions which is a major complication with adenomyosis. Same for the large fibroids also, but the small fibroids may not usually come in the way of growth of the pregnancy. Yolk sac, as we know, is the first visible embryonic structure. Stalk of the yolk sac can be followed to the embryonic abdomen as the vitelline duct. You can see the entire vitelline duct here. This is not an umbilical cord, this is an amniotic membrane here, this is amniotic membrane. Yolk sac usually, as we know, should appear 5-6 millimeter size, so 7 to 8 days after the visualization of the sac. Growth rate of the yolk sac is 0.1 millimeter a day, maximum 6 millimeters. Minimum should be at least 2 millimeters. But if the yolk sac is thick walled, it is solid looking, it is irregular, it is too small, that means lesser than 2 millimeters or larger than 2 millimeters, are all signs of abnormal. Too small yolk sac tells you there is not enough nutrition for the fetus, for the growing embryo. Too large yolk sac tells you the fetus is not thriving, and therefore the yolk sac is large. Degenerative changes in the yolk sac with the lack of translucency, that means starts becoming solid, and abundant calcification actually indicates a long-term fetal demise. Sometimes you may find double yolk sac. Double yolk sac, probably, yes, it does say, literature does say it may be morphological differentiation of a delayed disappearance of the physiological midgut herniation or an early abdominal wall defect, but most of the times it is overdiagnosed. Why do I say overdiagnosed is? At times it happens that the fetus has grown to about 6 weeks or so, 6 weeks plus, so the amniotic membrane starts developing, but the growth of the fetus stops there. Because the growth of the fetus stops there, therefore the amniotic cavity remains, which appears just by the side of the yolk sac. Therefore it appears like a double yolk sac, but actually it is not a double yolk sac. If it is truly a double yolk sac, it has to be 2 fetuses, and that would result in a monochorion. The CRL, the fetal pole, appears by about 5.5 to 6 weeks, located adjacent to the yolk sac. We have seen the complete development of the fetal pole. But if you, as I told you, if you see a gestational sac of more than 15 millimeter and you see no yolk sac, that is when it is a problem. It is very important for me to tell you here that whenever we are talking about the abnormal prognosis of the pregnancy, you should not depend on the days of last days after the last menstrual period, or don't depend on the weeks. You should always follow the size of the gestational sac. That is important in the early pregnancy, because not in all cases the the cycles may be regular, and not in all cases the pregnancy might have occurred at the same time, the 14th day or 17th day. The crown rump length, favorable, it should always be measured in the sagittal plane. So if you can identify the fetal parts, not this early, if you can identify the fetal parts, you should always measure it only in the mid-sagittal plane. And the fetal bole also normally grows at a rate of 1 millimeter a day. A slower growth may indicate a bad prognosis naturally. If you see a fetus of an embryonic bole of at least 5 millimeters with no cardiac activity, that is also a failed pregnancy. Yes, it is true that normally there is a difference. I mean, if there is a difference in the CRL of up to 5 days, that is when it is still considered normal, and you don't change the dates. But when the difference is more than 7 millimeters, there is a higher risk of chromosomal abnormalities. Though it is also true that it is trisomy 21 and 13 which may it may not be much affected, but for trisomy 18 it is a more reliable parameter. But whenever you find a short CRL, apart from the chromosomal and apart from failing growth of the fetus, also think of spinal canal abnormalities. In early major spinal canal defects, it is possible that the lower part of the spine is not developed, and for that reason the CRL may appear very, very short. That is when you are seeing the neural tube and you see sudden abruption of the neural tube, which is a sign which tells you there is probably a short CRL because of major spinal defects, and that can be seen as early as in the end of the first trimester. Heart rate, we know that the heart rate starts as very feeble pulsations. At the end of 5th week, it is like 100 per minute. End of 6th week, 105 to 130. 9 weeks, 160 to 170, and then settles at between 120 and 160. If the heart rate is too high, more than 200 per minute, you should think in terms of either cardiac abnormalities, but more commonly possibly trisomy 21, 13 or monosomy abs, and severe bradycardia less than 100 even beyond 7 weeks would tell you possibility of triplody or trisomy 18. Amniotic sac, which usually we ignore to see, but it must be seen, should be present at all times after end of 6 weeks. And if it becomes too hyperechoic, if it becomes thickened, this is a sign of abnormality. This is a sign of a bad prognosis. Too large or a too small amniotic sac, don't report it as an oligohydramnios at that stage, but do mention it is large or small, and that is important. What are the signs of failing pregnancy? A gestational sac which is growing at less than 4 millimeter a week, abnormal morphology of the yolk sac, large or small yolk sac, no growth or slow growth of the embryonic bole, bradycardia, and decreasing corpus luteal flow before 9 weeks. But these are the signs which tell you pregnancy is at risk. It looks like failing, it is not yet failed. Okay. But if you want to report this is surely a failed pregnancy, that is when you have to follow the guidelines. Yes, it is true that fetus normally, the embryonic bole normally should appear when the gestational sac is 15 millimeters. Normally appears at 10, you may wait till 15, but you do not report it as it will not appear if until you don't see a gestational you don't see a fetal bole when the gestational sac has reached 25 millimeters. Or you are not seeing a yolk sac when the gestational sac has reached 20 millimeters. Why these guidelines? Because once you report that it is not going to grow, that means it should not grow. It should not happen that you have told the patient the pregnancy is failed, this pregnancy is not going to grow, and in some rare 1% or 0.1% of cases, the patient will come back with 6 months of pregnancy. So that is why the guidelines are a bit strict and they are too wide. If the CRL, yes, it is true that if the gestational sac is not 25, it is 25 millimeters and you're not seeing the fetal bone, but when is a failing pregnancy, it would often happen that the gestational sac will grow at a lower pace, and therefore it is very difficult for it to reach 25 millimeters, and therefore if the gestational sac is not growing, is growing at half the rate of normal, or it is not growing, when you do 2 scans at an interval of 7 days, this is also an indication which allows you to tell the patient this pregnancy is a failed pregnancy, it is not going to grow. So, and similarly, when the embryonic pole, if it is not increasing, absence of the fetal pole in the gestational sac, and the sac is not increasing by 75% over a period of week, these are all the signs which tell you it is a failed, these are the signs which will tell you, which tell you, these are the guidelines, you can say it is a failed pregnancy. Blighted ovum. Blighted ovum, it is an anembryonic pregnancy where you are not seeing even the yolk sac. If the yolk sac has appeared and has disappeared, it is not a blighted ovum. That is a missed abortion. But if you are seeing no yolk sac at all, even when the gestational sac has grown beyond 10 millimeters, that is when you start suspecting it is a blighted ovum. If it does not grow, so if the volume of the yolk sac is less than 2.5 ml and is not increasing in size by at least 75% over a period of week, just like as earlier, and it doesn't have a yolk sac also, that's when you would say yes, it is a blighted ovum. Missed miscarriage or missed abortion, embryo without cardiac activity, no change in the intervillous blood flow is seen then. It is same as in the normal pregnancy. On the contrary, it is a low resistance flow. Why? Because the normal venous flow is a low resistance flow, whereas the fetal flow is a high resistance flow. Actually, when there is a fetus, there is actually a break on the blood flow because it passes through a higher resistance, and therefore the blood flow in the perisac blood flow is controlled. But if there is no fetus, it is a continuous low resistance blood flow. And therefore, it is in this case that you would see nearly normal blood flows or even lower resistance. We have talked about this already, but still vaginal bleeding, if there is there, it may be a threatened abortion, it may be a complete or incomplete abortion. Threatened abortion, we know the fetal gestational sac is still there, and you may or may not see perisac bleeding, not always. In every case where you have vaginal bleeding, you will see perisac bleeding also. In that case, so perisac bleed is different, threatened abortion is different. These are two absolutely separate things and must be reported separately. Intrauterine hematoma, that is what we discussed already. Now coming to the prognosis of the pregnancy in cases with perisac bleed, I have already told you size, location of the hematoma are the two important things. We have discussed this already, so let's go further. Pregnancy with uterine abnormalities, it may be congenital abnormalities of the uterus or the Mullerian abnormalities in which there may be pregnancies. It may be present in the bicornuate, it may be present in the septate uteri, it may be present in the unicornuate uterus. Remember any of the things, though yes, it is true that the septate uterus has been blamed a lot for infertility and also for the ectopic pregnancies and all. It is true, it's all true, but that doesn't mean that there is no pregnancy with septate uteri. There are quite a few septate uterus that you also maybe have operated for a cesarean section. So that is quite common, and you may often see this. What is important is when there are any of these congenital or the Mullerian abnormalities and the pregnancy are there, most of these cases.
In all these cases, the risk is more often early labor, and in all these cases it is cervical encerclage, and it is progesterone which plays a very important role to
pull on the pregnancy till at least 35 to 36 weeks, and that can result into a viable fetus. Pregnancy with fibroids and adenomatic uterus, we have already discussed. IUCDs, sometimes there may be pregnancies with IUCDs, especially when they are displaced IUCDs, and that is one important thing. Coming to the molar pregnancies. Molar pregnancies are one of the common complications of gestation, estimated to occur in one on every 1,000 or 2,000 pregnancies. Occurrence is higher in the pregnant women in their teens. So if the pregnancy is in the extremes of the age, that's when the incidence is more. In Asia, it is much more. It will have very high beta-HCG levels, which you all know. And there are two types of it. It may be a complete molar pregnancy. It may be an incomplete or a partial molar pregnancy. Partial molar pregnancy is a bit difficult to diagnose correctly because the fetus is there and it is normal, and the placental tissue shows a little more. So a little more thickness and little more anechoic areas. That makes the diagnosis quite difficult. Whereas complete mole, we know that it is usually very clearly thickened endometrium, multiple anechoic areas, bunch of grapes-like appearance, and it, as if it develops to a larger size, it may show a lot of vascularity. But it is very important. So in the morning I was asking somebody, chromosomal study has been done or not. Chromosomal pattern for both is different. 90% of the complete hereditary form moles have 46XX diploid chromosomal pattern. All the chromosomes are derived from the single sperm. In 90% or less likely there will be two sperms, meaning the fertilization of a single egg that has lost its chromosomes. So that is what creates a complete molar pregnancy. But when it is an incomplete or a partial mole, there is a normal fetus. So there is 46XY or XX, and then there is a further pair, further entire set of chromosomes. So it is more of a triploid chromosomal arrangement. But it is easier if you want to differentiate between chromosomes, complete and partial mole, where ultrasound is difficult. You can try immunohistochemistry. Immunohistochemistry with P57, it shows absent staining in the complete mole, whereas it does show positive staining in the partial mole and in the hydropic abortus. It is useful, it is cheaper comparatively, and can help distinguishing between complete mole from all its mimics. We already have seen bunch of race appearance or a snowstorm appearance, and a lot of vascularity, and bilateral or unilateral very active theca-lutein cysts are what are the signs of molar pregnancy. Molar pregnancy, when they are complete, that is when it is more likely to go into an invasive nature, as long as you are seeing an intact endomyojunction. As you saw here, the prognosis is quite good. But if you are not seeing a clear endomyojunction, it may be invasive and it may be extending into the myometrium. That is when you would see that it's a hyperechoic tissue which is extending into the myometrium. If you put on a Doppler, both the endometrium and the myometrium shows almost equal vascularity, and the vascular strands are seen extending right up to the myometrium, sometimes up to the serosa. So that is what is diagnostic of the mole. In the patients with complete mole, the possibility of development of choriocarcinoma or invasive mole increases significantly. Partial mole, whereas yes there is pregnancy, yes there is fetus, in the very early pregnancy the fetus appears normal, but in some cases it is the partial mole that weans, and when it weans, that's when the circulation increases significantly. Because of the increased circulation, there is overload on the heart, and that would lead to fetal demise in these cases. So if there is a partial mole, initially you need to follow it very closely. Some of the pregnancies may progress as normal pregnancy, but in some of the other fetuses, because of the cardiac failure, there will be a hydropic fetus. Chorioangiomas, they are often reported as chorionic bumps, hyperechoic, ball-like projectile lesions with smooth margins. Put on a Doppler, it will show the same vascularity as the placenta, has a feeder vessel. Small chorionic bumps, they do disappear on their own. but if they grow into the second trimester, they are likely to lead to hyper circulatory states and therefore will result into a cardiac failure of the fetus. The abnormalities that you can diagnose in the first trimester, the cranium, which the tool of choice is transvaginal scan. Bleeding during the pregnancy is not a contraindication to assessment of the from the vaginal route. Thank you very much. And I guess do we want to stop there? Thank you very much. I would just want to tell you one small thing, because I was going to talk on ectopic, but I have not talked on ectopic. If you want to, just one or two important things that I want to tell you. Ectopics, any adnexal mass, even if it is isoechoic, seen in a patient in whom you have the patient has a history of a missed period and a positive beta HCG, tender on probe pressure, unless proved otherwise, it is an ectopic pregnancy. This first appears as an isoechoic mass, then a central hyperechoic area, and then an anechoic gestation sac. But even before you can see that, you will be able to see the thickened endometrium with symmetrical lips or a non-thickened endometrium. If you see asymmetry, as I showed earlier, it is a sign of an early intrauterine pregnancy and not an ectopic pregnancy. You all know how to differentiate between a pseudo sac and a true sac: vascularity, decidual sign, eccentric or central location, and change in shape with peristalsis. Right? Very important to differentiate between the angular pregnancy and the interstitial pregnancy, because it is the interstitial pregnancy which requires immediate action, and it is the angular pregnancy which most of the times grows inside the endometrium and therefore is safe. If you see, the only risk is adherent placenta. If you see on the transverse section, you are seeing the endometrial, you are seeing the endometrial cavity, you are seeing the myometrial mantle, and you are seeing the gestational sac separately. This is an interstitial pregnancy, but if you see that there is a gestational sac which is medially covered by the endometrial cavity, this is an angular pregnancy. So angular pregnancy, safe. Interstitial pregnancy requires immediate treatment. Similarly, and 3D is very useful. Similarly, differentiating between the cervical pregnancy and pregnancy in process of abortion. Cervical pregnancy is eccentric. It has ring of color. It does not change its shape on rotation on probe pressure, and it is painful on probe pressure. Most of the people say open internal loss, but open internal loss may be seen, may not always be seen. So it is very important to depend, and peripheral vascularity in the cervical pregnancy. So those are the important points. Thank you very much, and sorry for not including everything.
And for your excellent learning style and also the presentation we admire. And thank you on behalf of Chittagong Medical College Gynae Department and also the Chittagong branch. All the participants are here. And I think in between the lecture there are so many question answer, madam answered. And now we have come to the end of the session. Our principal, head of the department, Professor Shahena, will give a memento to our today's speaker. And we are very much grateful, like as it is, to Professor Rokeya Madam, who always is a source of our inspiration, always guiding us. She is the person who communicated with Dr. Sonal Panchal, a legendary of infertility era, and there are young gynecologists here. All are inspired to have this training, and they are very much happy. Thank you very much, madam. Now I will request Professor Shahena madam to present the crest, our symbol of respect to our honorable.
Okay. Madam, একটু থাকাই, ম্যাডাম একটু প্লিজ একটু থাকাই। হ্যাঁ প্লিজ ম্যাডাম একটু দূরে থাকাই, ম্যাডাম একটু দূরে।
It's a very token of love from our society and also department. First, there is a token of gift from Professor Rokeya madam to you.
হ্যাঁ ম্যাডাম প্লিজ একটু সামনে, ম্যাডাম সামনে থাকা, একটু সামনে। থ্যাংক ইউ।
Also, there is a gift from Department of Gynae and Obstetrics.
Thank you.
Madam will leave tomorrow. Pray for her and all the best wishes for the madam, and come back soon. We will be very happy to see you again here. Thank you, madam.
Thanks to all the participants and Nuvista.
Thank you all the participants for remaining the whole day with us, and our scientific partner Nuvista. The whole team did a really excellent job. Please a big clap.
প্লিজ এই পাশে বসে, এই পাশে গ্যাপে বসে।